And it's over to our Dr. Bhupendra and Dr. Afsana to start the scientific session. Please.
Ladies and gentlemen, on behalf of Indian Medical Association Vadodara branch, which is the host of the most prestigious 74th Annual State Conference, Gimacon 2022, I, Dr. Bhupendra Kapadia, immediate past Honorary Secretary,
and I, Dr. Afsana Patel, MOC of today,
would like to extend a warm welcome to all the doctors and medical students who have come from in and around Vadodara and Gujarat for our Gimacon 2022. We welcome you all smart medical graduates on this beautiful smart Sunday and then Sunday. This year's conference is especially important because it is the first state level conference of Indian Medical Association happening after COVID-19 pandemic. We are honored to have such a distinguished group of doctors and medical students in attendance today. Friends, Alvin Toffler said, the illiterate of the 21st century will not be those who cannot read and write, but those who cannot learn, unlearn and relearn. So, we are ready to serve you an academic feast, and I assure you all that you all will like it most, as it's having very good talks by some of the leading experts in the field. We encourage you to take the full advantage of this opportunity to network with your peers in person, which is a very rare opportunity nowadays, and expand your all different kinds of knowledge today, so that together we can continue to raise the standards of medical care. Thank you for being here with us today, and we wish you a fruitful conference. Again, it's an honor more than a pleasure to welcome you all. Friends, it's our culture and not just a tradition that we start our any learning programs, CMEs, seminars, conferences with IMA prayer and flag salutation. So I request all to stand for the prayer and then flag salutation. Vakratunda Mahakaya Surya Koti Samaprabha Nirvignam Kuru Me Deva Sarva Karyesu Sarvada. I am a prayer. May everybody be happy. May every one of us see to it that nobody suffers from any pain or sorrow. I do not ask for crown, nor I wish to be in heaven or reborn. I only want to alleviate the suffering of those people who are burning in the fire of sorrow. I am a flag salutation. We, the members of Indian Medical Association, stand here to salute our national flag. Its honor and glory shall be our light and strength, and its course shall be our course. We pledge our allegiance to it, and realizing our responsibilities as the accredited members of this national organization. We swear we will dedicate everything in our power to see it fly high in the Committee of Nations. Jai Hind. Please be seated. Without wasting much time, we begin our conference, and for that, I welcome our young, dynamic and intelligent chairpersons, Dr. Suresh Damor, Dr. Ketan Shah and Dr. Jasmine Jasani on the stage. Dr. Suresh Damor is a senior consultant physician practicing in Nizampura, Vadodara. Dr. Ketan Shah, a senior family physician, and Jasmine Jasani is a senior pathologist and medical superintendent at Dheeraj General Hospital and Sumandip Vidyapith. They all are senior by experience and very young by heart. They all are good friends of all at our own IMA house. We have a very tightly packed schedule today, and I would request all the speakers of today to be a stickler of their allotted time. You will have a timer on your screen and an alarm ringing just 2 minutes before your allotted time is about to get over. Now, I welcome our opening batsman of a historical conference, that is Gimacon 2022, Dr. Piyush Chandra on the stage for his first talk on redefining precision healthcare using advanced nuclear medicine technologies. Now, over to chairpersons to introduce Dr. Piyush Chandra, sir.
Good morning, everybody. Welcome to Gimacon 2022. Dr. Piyush Chandra, MD, DNB, Feb NM, Consultant Nuclear Medicine. He is trained in nuclear medicine from Tata Memorial Center, Mumbai. He is a gold medalist DNB Nuclear Medicine. He has done hybrid imaging radionuclides therapy. He has publication 42 PubMed Index Journal. Yeah.
Very good morning to everyone. I thank you, Chairperson, for the warm introduction. It's an honor for me and our hospital to be invited here and to be given a chance to present our work. So I'll be talking today on advanced nuclear medicine and what innovations nuclear medicine as a specialty has gone through all these years. So when we talk about precision healthcare, it starts from prevention of disease in at-risk patients, diagnosis, early diagnosis and correct diagnosis, precise diagnosis in patients with symptoms. When they do get diagnosed with the disease, what is their prognosis, how is their treatment going to be, and then charting out a personalized treatment for such patients. And nuclear medicine is at the center of what we call it as precision healthcare. Nuclear medicine originated before the independence in 1945 when the first radioiodine therapy was given for thyroid cancer. In 1970s and 80s, it got into mainstream clinical imaging. You can see the first PET scan, which was done on a rectilinear scanner. And you can see the brain of a patient, which was the first PET scan ever done in a patient. Lung perfusion, ventilation was the standard of care. Still it is for diagnosis of thromboembolism. But now, fast forward to 2022, things are much clearer. We are seeing molecular imaging fused with the anatomical imaging, the CT scan, the MRI, and you get much better clarity. And it is being rapidly integrated into management of not just cancer, but across diseases of the lungs, of the heart, endocrinology, and nephrology. So what exactly has changed the face of nuclear medicine? I think when we integrated with anatomical imaging, that was the game changer. So now we have no longer the gamma camera, but we have a 3D gamma camera called the SPECT CT. PET CT now is the standard of care in oncology. PET MR is on the horizon. And also whole body PET, which will do your PET scan much faster than the routine PET scanners. Research in radiopharmaceuticals, molecular physics, we don't have just technetium-99 and iodine-131, but now we have fluorine-18, gallium-68, C11, and therapeutic isotopes. Nuclear medicine is not just limited to diagnosis, but also therapy. So we have isotopes like lutetium, actinium, and yttrium. Research in radiochemistry, developing precise targets for cancer-specific imaging and treatment. And now nuclear medicine, just like your pharmacology, is considered as a radiopharmaceutical, and a lot of clinical trials are underway and already done. And we see rapid integration of this in mainstream clinical medicine. Before I go to the innovation, I just want to stress on certain old scans which has no replacement, just like a chest X-ray has a no replacement. I would acknowledge that all of you sitting here would say that without the thyroid scan for a hyperthyroidism, we cannot give a precise treatment, whether it's Graves' disease, Plummer's nodules, or multinodular goiter. Pediatric urologists will feel without DTPA scan, we cannot operate antenatal hydronephrosis. Not all babies born with hydronephrosis need surgery, and DTPA scan is the gold standard to decide whether to do surgery or not. DMSA scan for babies with reflux, vesicouretery reflux, is it really significant? And if DMSA shows scars, I think these patients really benefit with reimplantation surgery. So these are gold standard scans. And another gold standard scan is stress thallium or SESTA maybe in patients with low and intermediate risk. Heart disease is very common, also seen in young age. And over past 4 decades, we have seen the sensitivity and specificity is excellent. I mean, there is no other non-invasive scan to tell whether you have coronary artery disease or not. And it is prognostic. If you have a normal stress thallium, your chance of getting a fatal MI or a cardiac death is just 0.45% over the next 3 years. And it is 7% after your scan is abnormal. So it helps, it's a very good gatekeeper of the invasive angiography. So now we have to innovate. Innovation is the ability to see a change, not to see a change as an opportunity and not as a threat. Times magazine in year 2000 just published an article saying that the PET-CT is one of the invention of the year. And indeed, after 2 decades, PET-CT is now done in every cancer patients, especially breast, lung, prostate. But now we have moved on from imaging just the disease, but to image the receptors, just as they do on immunohistochemistry. So we can image the glycolytic activity of the tumor, see it spread, but also measure the estrogen receptors. We should understand in solid tumors, if the patient has disease in the bones, in the liver, the morphology of all these tumors are not same. Solid tumor is heterogeneous, whereas the hematological tumors are arising from the single clone, so they are homogeneous. So a tumor may express estrogen receptors, they may express HER2, but you will biopsy just a single site. So molecular imaging can give you in vivo expression of these molecules and decide treatment. So we can image the receptors, we can image the tumor stroma, we can image the tumor angiogenesis and direct treatment. This is really very advanced cancer treatments, and they are making cancer treatments very easy for the oncologist. Prostate cancer is the next commonest cancer in a male, at least in the males, it is the commonest cancer we see in our country also. Previously, we used to do bone scans. A bone scan will take at least 4 hours for staging of the disease once it is diagnosed. Now we know PSMA PET. PSMA stands for prostate-specific membrane antigen, which is expressed on every prostate cancer cell. So we tag it with an isotope, inject the patient, and you can see nice images compared to the bone scan, which hardly shows any lesion. So now PSMA PET has become a one-stop shop cancer imaging for diagnosis, for staging, for identification of recurrence, and for planning PSMA therapy, which I'll come back to you later on. We did a study 4 years back where we diagnosed prostate cancer prior to biopsy in patients with PSA less than 50 nanogram per ml. And we found the accuracy to be around 86%. This is as good or better than clinical diagnosis, algorithm-based or MRI diagnosis. And now rapidly, especially in the European continent, PSMA is integrated prior to biopsy to improve the diagnosis. We call mammogram for breast cancer. Maybe PSMA PET-MR will be called as the manogram, because we can fuse the PSMA PET with the MR and we can get excellent diagnosis. What MR can miss, PSMA PET-MR can pick it up. And studies have shown that it is more accurate. And I think if your PSMA PET-MR is negative, maybe you will not undergo invasive biopsies. Invasive biopsies carries a risk of infection, bleeding, and most of the patients don't need it. So almost 50% of the biopsies, prostate biopsies, come out as negative because we just go by PSA rise. PSA can rise in prostatitis, BPH, everything. Neuroendocrine tumors is one domain after thyroid where nuclear medicine has contributed a lot, because on CT scan, you may see it as a 1 centimeter nodule in the duodenum, but if you do a PET scan, you will see that they have spread. These tumors are very well known to spread even when they are small, because they are endocrine malignancies. So neuroendocrine tumors, now we can stage them because these express somatostatin receptors. We can image with DOTA-TATE scans for diagnosis, for even NETs, which are not the classical NETs like pheochromocytomas, meningiomas. They are very nicely seen on this scan, and they add value over MRI. The most important contribution of nuclear medicine is not in diagnosis but treatment, PRRT therapy, which I'll show in subsequent slides. Nuclear medicine is not limited to oncology. It is not radiation oncology. So I think, and there is a lot of role. I have stored coronary artery disease. You may have patients with cardiac amyloidosis, patient with restrictive cardiomyopathy, an LV wall which is thickened, but your ECG is showing low voltage, we should suspect amyloidosis. And amyloidosis can be nicely seen on the pyrophosphate scan. You can see on the right-hand side. Intense heart uptake by the pyrophosphate is diagnostic of a cardiac amyloidosis. Heart and brain, we cannot put needles. And in these organs, molecular imaging really gives you the in vivo diagnosis. Cardiac sarcoidosis, patient may present with heart blocks, congestive heart failure, maybe even tachycardia. And now cardiac sarcoidosis are diagnosed by FDG PET and MRI together. And you don't need an endomyocardial biopsy anymore. This is integrated into all the cardiology guidelines. Vasculitis, you would all say it is diagnosed with a simple blood test, but PET scan can nicely show what is happening inside the body. You can see here intense uptake in the aorta and its branches in a large cell vasculitis. Basically, what is the use of FDG PET? Basically, you can use it for tailoring the treatment. When do you stop the steroids or immunosuppressive treatments? Because diagnosis, as you can do it blood test, but following up these patients is difficult, and PET scan is a very good modality for the same. We can pick up hidden infection patients with fever of unknown origin for 2-3 weeks. This patient presented us with a heel pain and nothing else, and we did an MRI. It showed some lesion, some signal abnormality in the calcaneum, but there was no other disease. So we did a PET scan, and we can nicely see the paratracheal and the supraclavicular nodes, and just assessment of the lungs also showed some tiny tree-in-bud nodules. So this was a case of tuberculosis. If we had not done a PET scan, we will not know from where to biopsy. So PET scans guides you, the site of biopsy gives you a diagnosis. Patient with autoimmune encephalitis will generally have a normal MRI. In this patient had facial brachio seizures, and he had a normal MRI, but when we did a PET, there was intense hypermetabolism in the left mesial temporal lobe, and blood test showed an anti-LGI1 encephalitis. And these patients were managed with steroids and improved. So PET scan is a gold standard for autoimmune encephalitis. This disease before 2010 was not discussed or published, but I think it's rapidly coming into the mainstream, and many patients, old patients, presenting with seizures and normal MRI, you should suspect autoimmune encephalitis, and PET will give you the diagnosis. Diagnosis of dementia is important. Every patient of memory disturbance may not be Alzheimer's disease. It may be a Lewy body dementia, or it may be a genetic condition called frontotemporal dementia, which is inherited in families. So PET scan can differentiate. If you have a parieto-temporal hypometabolism, it is usually Alzheimer's. If you have diffuse disease with basal ganglia involvement, it is a Lewy body dementia. If you have predominantly frontal hypometabolism, you will have a behavioral type of frontotemporal dementia, or you have a anterior temporal lobe involvement, you can have a non-fluent aphasia. So PET scan can give you an in vivo diagnosis, which is only possible if you don't do a PET scan by autopsy. Parkinson's disease, not every patient with bradykinase and rigidity is idiopathic Parkinson's disease. So if you do PET scans for such patients, you will see that to start with, there is loss in the posterior putamen initially, and as the disease progresses, the reduction of the DOPA uptake will be seen in both the basal ganglia. In patient with essential tremors, patient with drug-induced Parkinsonism, your DOPA PET will be negative. So neurologists frequently ask us F-DOPA PET to differentiate, and all these modalities are available in our city, in the rest of the state of Gujarat. So atypical Parkinson's disease, they don't respond to SYNDOPA. Actually, it may get worse if you start SYNDOPA, and knowing what type of atypical Parkinson disease helps manage the patient better. So multisystemic atrophy, progressive supranuclear palsy, and corticobasal degeneration, these are certain atypical Parkinsonism with characteristic FDG PET findings. So you can have conventional imaging in your hospital, but it may not always give you a precise and accurate diagnosis. Molecular imaging gives you a precise and accurate diagnosis. Both is important if you want to really give a personalized, precise treatment. Just to finish my slide, I want to introduce what is called as theranostics. Nuclear medicine, as I said, it's not about just imaging cancer, but also for treatment. Radioiodine therapy, as I said, originates from 1945, and now over the years has been the standard of care for thyroid carcinoma treatment. and it was the ideal theranostic. Theranostic means you are imaging with the same molecule and increase the dose of the same molecule, give it systemically to the patient, and it causes treatment. So in this case, you can see a pre-therapy scan just showing a neck node disease, and after the therapy, you can see intense uptake in the lung, and it is also a treatment for the patient. So now we have moved from radioiodine, now we are treating neuroendocrine tumors. This is a patient which presented with duodenal NET with multiple liver metastasis, and we treated with something called as lutetium dotatate, and patient has achieved complete metabolic response. This was not possible few years back, and now FDA has approved it as a standard treatment for metastatic NET. Prostate cancer also, as I said, PSMA, we can image the patient, and with the same molecule, just changing the radioisotope from gallium to lutetium-177, we can treat the patient. So these patients we imaged, we showed bone metastasis, and then gave 2 cycles every 2 months, and then you can see complete metabolic response. The beauty of such treatment is no hair fall, no neutropenia, and it is a daycare procedure. Does theranostic really work? They say it is just fancy images, but does it work? So now this was published in New England Journal in 2017, where metastatic prostate cancers, it was shown that lutetium has better value than enzalutamide, and now it is integrated into the treatment of castrate-resistant prostate cancer. You can see the Kaplan-Meier curve showing better survival compared to the standard of care. Also for neuroendocrine tumors, in the New England Journal, it was shown that dotatate compared to sorafenib and the sandostatin alone has much better progression-free survival and overall survival. And now these 2 drugs, the dotatate and the PSMA 617, now is marketed by Novartis, and they are distributing it in the rest of the world. In India, we use generic, which comes from Baba Atomic Research Center, and it is 1/10 of the cost, and the treatment efficacy is the same. So we should credit, at least I credit BRC a lot, Baba Atomic Research Centers, because we are a much bigger powerhouse in nuclear medicine than the rest of the world. Because we give alternative cheap treatments as well as efficacious as the branded medicine. I take this opportunity to invite all of you to my hospital in Zydus Hospital and to showcase what all we have for our patients. I thank you for your patient listening.
Thank you, sir. Any question? Okay. Now I request all the audience to stand up for benefit of both speaker and yourself, just to get relief spasm, please.
Thank you, thank you.
Thank you, sir,
Thank you.
for such an awesome batting. Now I welcome Dr. Piyush Chandra, sir, down the stage for the felicitation of Dr. Piyush Chandra. I request Dr. Suresh Damor, sir, to present the memento to sir. Now I welcome Dr. Ashish Sethi, sir, on the stage for his next talk for the most important topic of nowadays is non-alcoholic steatohepatitis, diet, drugs and drills, not by Instagram drills. So welcome, sir, on the stage, for which I request all chairpersons to introduce Ashish Sethi, sir.
Good morning all. Dr. Ashish Sethi is a MD DM in gastroenterologist. He awarded first rank in first MBBS, second MBBS, and second rank in third MBBS. He awarded gold medal in anatomy, physiology, biochemistry, and pathology. He published various national and international papers in reputed journal. He conducted various clinical trials with leading pharmaceutical companies. He is a member of ethics committee of Sun Pharma. Now I request Dr. Ashish Sethi, sir, to start his session. Thank you, sir.
Good morning, everybody. I thank the organizers, especially Neeraj, for such a wonderful scientific content of this meeting, and the organizers for such a beautiful conference. I thank the chairpersons for the welcome. I'll start off my talk with something on what is NASH. Now, basically, previously there was something like non-infective and infective disorders, We used to say this is an infective. Now, COVID has shown us that there is an interplay between the infective and the non-infective disorders. We all know the morbidity and mortality of COVID is much more in patients with having metabolic syndrome. So what does NASH include? Basically, NASH includes everything when we start from fatty liver down to steatohepatitis, where the SGOT, SGPTs rise, means the liver inflammation starts. Then the cirrhosis appears. Then in between you can have hepatocellular carcinoma. So there's a huge spectrum of the disease. And NASH is not a disease which will restrict to the liver. Basically, NASH is a systemic disease. So what is different aspects of NASH that I'll show you. But NASH is almost the first marker of the metabolic syndrome. So a person of 35 or 40 years or maybe 25 years, and nowadays even 15 years comes to you with a fatty liver, you know that the metabolic syndrome has started in this patient. So NASH becomes almost the first marker of the diseases the patient is going to face in the next 15 or 20 or 25 years in life. So already you have a roadmap of the patient before he develops the disease, maybe 20 years before. So now we have to act on that roadmap. So these are the various components of the NASH syndrome or the metabolic syndrome. Each and every organ system is affected. And so our treatment here will not be the treatment of NASH. It will be the treatment of the metabolic syndrome. In fact, the treatment of the whole non-infective disorder spectrum that we face today. So what is the basic two causes of NASH? Before I go on to the management, we should know something about the causes so that we can understand the management, or you can implement your own management protocols. Basically, two main causes, the insulin resistance and the obesity. So if you have a patient with insulin resistance and obesity and both of them are interplaying among themselves, then this patient is going to have NASH. So what we find here, that there is insulin resistance, visceral obesity may be the initial event in the patient leading on to insulin resistance and then the release of inflammatory mediators and then NASH. Just remember the first two things, visceral obesity and insulin resistance. Next. So what is the visceral obesity? Now visceral obesity is of two types, the apple type and the pear type. I will just go into details of that. Basically, this is the upper body obesity and this is the lower. This is the obesity we commonly see in females, and this is the apple obesity which we find in the patients with NASH. So what happens in these two? Basically in Indians what we have a problem is, we don't have very large sub-Q space. We are living in a hot country. Our sub-Q space is not very large. So what the fat tends to deposit in the abdominal cavity and not in the subcutaneous tissues. That is why we Indians are more prone to develop visceral obesity of the apple phenotype, where the abdominal girth is much more than the waist circumference. So what is the problem with visceral obesity? Visceral obesity leads to a state of insulin resistance because of a lot of fat inflammation present in the abdominal cavity. So what happens when you have insulin resistance because of the visceral obesity or maybe idiopathic insulin resistance? Basically, the two main causes of these two things are visceral obesity and insulin resistance are dysnutrition. I won't call it as overnutrition, we'll call it dysnutrition, and lack of physical activity. So the treatment of NASH will start with the treatment of these two things, the physical activity and the nutrition. So how do you tackle the visceral obesity and the insulin resistance? You have to increase the physical activity and you have to correct the nutrition. The main problem with lack of physical activity leads to a state of insulin resistance in the muscular tissues. The muscles do not take effect, the effect of insulin is decreased on the muscle tissues, and that is the main thing which leads to obesity. You have lack of adequate physical activities, your calories in will be always more than the calories out. So how do you improve the physical activity? Any form of physical activity is good enough. It's not like yoga is better or aerobics are better or endurance is better. If you are fidgeting is a difficulty in sitting at one place. So any form of physical activity can help you, and this helps even if you don't have weight loss because it improves the muscle insulin sensitivity. So all forms of physical activity are good. So how do you go about those physical activity? Basically, this helps in utilizing the fat as a fuel by decreasing the beta activity. The fat in the body is used up for promoting, for using up the calories, so it helps in ketogenesis. So fat is converted into ketone bodies, and then ketone bodies are used up by the body, increases the muscle blood flow and improves the insulin resistance. So how do you exercise? I'll go on to that. So basically, it's not like you have to go all out and exercise and get tired in 5 minutes. You should try to exercise between 60 to 70% of your heart rate. So if your heart rate is, how do you calculate your peak heart rate? Usually it is 220 minus your age. So you have 60 years old, you minus 220 minus 60 is 160, and that is your peak heart rate. And then you work out at a rate of around 60% of that. So maybe around 120, 110. So this is how you should work out. And how do you know that you are working at the 60 to 70% of your heart rate? Basically, if you are able to speak short sentences only while walking or running or cycling, that means you are not going overboard and you are not going very slow. So it is very easy way to know, just speaking 2-3 lines, how are you, or hu saro chu, this is short sentences you are able to speak, then you are doing properly in a zone 2. So you should always try to work out in zone 2. Zone 2 workout helps in burning out the fat. If you go to zone 3 or zone 4, you are using up carbohydrates and then you feel hungry and then you eat after the workout. So if you're working in zone 2, you don't feel so hungry and you won't eat out of the workout. So it's the fat which is going to burn. So the best workout will be in zone 2. Usually the recommendations are 150 minutes of any activity of around keeping a heart rate around 60 to 70%, 150 minutes, that is maybe around 2.5 hours per week. So that is sufficient to maintain your physical life. So this is the same thing which I have told you. Your aim is to work out in zone 2, which is around 60 to 70% of heart rate. Whatever you do, whether you yoga, stretching, aerobics, and aerobics is running or walking or cycling, or strength training, which is lifting of weights or squats or push-ups, whatever you do. So anything you should try to work out in 60 to 70%. So this is how you know your in 60 to 70% your muscles are little bit fatigued but not over fatigued. This is my impression. I used to have a cholesterol of 220 and a triglycerides of more than 150, and after doing lots of exercise, I have reduced my cholesterol and reduced my triglycerides and of course reduced my weight from 100 to 70 kgs. The second important thing is dysnutrition. So I won't say that you are if nourished. You should have to balance between whether your calorie intakes are out and in, that is an important thing, but what sort of calorie intakes you are taking. So I'll stress on two things, is excess calorie intake and excess carb intake as compared to fats and proteins. The fat is the preferred form of body storage because it is very dense. Carbohydrates are very bulky, so body usually stores all the excess calories as fats. So this is why visceral obesity occurs, because and as I explained to you, visceral obesity occurs in the Indians more commonly because we have less sub-Q space, very hot climate, we don't need fat in our sub-Q to protect against the cold. So our fat is stored in the abdominal cavity. So overall the first message of dysnutrition or treatment of NASH is always decrease the calories. Target should be 1500 calories per day. So if you can count the calories, that is very good. So you should not, if you want to really work out or reduce the NASH, first target is to reduce the obesity, and that is first is to reduce the number of calories you intake. So I'll first go to the amount of calories you take. So 1500 calories per day should be your target. You can have so many calorie counters available on the applications. Two are very important. One is Fitness My Pal and second is Fat Secret. So these two applications will help you know the number of calories available in the Indian food. So there are two ways of reducing the calories. You can eat less, or you can have 5-2 method, which is the Indian method where we fast. So fasting is very good. Otherwise, you can fast for 2 days and eat for 5 days. So second is the fasting method, and second is the Jain method, which is very rational. You eat for only 6 to 8 hours a day and fast for 16 hours. So these two methods are very good methods for reducing the amount of calories intake per day. Second is the dysnutrition, that is the differentiation between the carbs, the proteins, and the fats you are taking. So Indian diet contains 64% carbs. Now carbs have a problem. The carbs are very easily converted into fats, especially fructose. The main problem with carb is the amount of satiety which we get from taking carbs is less as compared to proteins. The carbs are very maximum stimulators of insulin. I'll come to the problems of insulin in the next slide. They are very easily converted into triglycerides, and they also produce intestinal bacterial overgrowths. So what are the problems with carbs? Poor satiety, insulin levels are increased, intestinal inflammation is occurred, and they are of course stored as triglycerides. What does the increased insulin levels do? So insulin is the main driver of cell growth, and excessive cell growth, as we all leads to cancer. So insulin is the most important causes of growth of cancer nowadays. Insulin also promotes the deposition of fat in the liver, that is the NASH, and rapid changes in insulin level leads to hunger. So if you eat sugars, your insulin level will go high, your sugars will fall, and you will get hunger. So this is the problem with it. So insulin levels lead to rapid changes in sugar and rapid hunger pangs, and that leads to overeating. So how to decrease the carb intake? So the problem with the advantages with using excess proteins is proteins produce good satiety. So if you get a good protein diet, you eat less because your stomach gets filled up early. Of course, it promotes muscle growth, and so ultimately muscle growth decreases the insulin resistance. The problem with the protein diet is most of us are vegetarians, and otherwise the protein diet is a little bit costly. Second is fat. So if you increase the fat in diet, again it promotes early satiety. Also ketosis is very good. It also promotes satiety, but the problem again is fat, vegetarians, and calorie intake may not be less because fats are very calorie dense. And of course fat intake increases the LDL level. So I don't know how much importance is there in LDL, so that can be discussed in a separate lecture also. So we don't know what is the exact best way of reducing the diet, whether we go for a keto diet or we go for a low carb diet or we go for a low fat diet. So what I usually suggest is you decrease the calorie intakes overall, try to increase the fat protein intake, keep the fats as they are, don't try to go for a increased fat intake. So by decreasing the carb intake, how do you decrease the carb intake? Basically very easy to stop sugars. So you stop all types of sugars, refined sugars, and stop all processed foods. Very easy to say, very difficult to follow, but this really helps. If you can decrease the sugar intake, the processed food intake, your job is almost done for taking care of the dysnutrition. Then I come to the drugs. So we have covered the drills, which is the exercise. We covered the diet, and the least important thing is the drug. Drugs here are very specific for the liver, and they can be used for the whole metabolic syndrome. But diet and exercise helps in treatment of the whole body. So first treatment of any patient of NASH or the metabolic syndrome will always be diet and exercise. So what other drugs we have in NASH? We have vitamin E, we have antidiabetics, we have saroglitazar, and we have obeticholic acid. These are all drugs are available in India, and I'll just show you how to use them. So we have an excellent trial of vitamin E and pioglitazone. Pioglitazone, of course, is anti-diabetic. 30 milligram was used. Vitamin E dose was 800 milligrams per day. And this was published in NEJM 12 years back. And both of them have been found to be useful. They decrease the steatosis and decrease the fibrosis both. So they are very good drugs for NASH. The problem with vitamin E, it increases the risk of prostate cancer and, of course, hemorrhagic strokes. So anyone beyond 60 years of age, you will have some hesitation in using high dose vitamin E. So usually we don't prefer, and most of our NASH patients will be reaching 60 years or so. The problem with pioglitazone, as we all know, is weight gain and bladder cancer. So again, these two drugs have not very picked up in the treatment of NASH, but they are available, and in selected cases they can be used. Then we have another two antidiabetics which have been used in the treatment of NASH is GLP-1 analogs, which is liraglutide, semaglutide. The advantage with these glutides is they decrease the oral intake. They have some gastric effect. They decrease the gastric emptying, and they decrease the appetite, and they can cause some weight loss and improve the NASH. Maybe SGLT2R will be better because SGLT2 inhibitors, as we all know, they decrease the glucose levels. And anything which decreases the glucose levels will ultimately decrease the insulin levels. So maybe SGL2 will be a better drugs as compared to the other drugs in treatment of NASH. But still, we don't have so much data on SGL2 inhibitors, but most of our patients will be on SGL2 inhibitors because they are diabetic. So it is better to use them as a treatment of NASH also. Then we have the seraglutazar. Seraglutazar is a combination of pioglitazone and fenofibrate. So basically, it decreases the triglycerides and decreases the sugar. So it's one of the very good drugs for treatment of NASH. Of course, researched and brought out in India only, because it improves the insulin sensitivity, which is the main cause of NASH, where we know that insulin resistance is the main cause of NASH, and it decreases the triglyceride levels also. So seraglutazar is again a good drug for the treatment of NASH. The problem with seraglutazar, we don't have still data whether it decreases the fibrosis in NASH. So, but we have data it decreases the steatosis in NASH. Then we have obeticholic acid. The obeticholic acid was the very excellent molecule for the treatment of NASH, but I am telling because we still don't know whether it can cause harm in NASH. The problem with obeticholic acid is the advantage of obeticholic acid decreases steatosis as well as fibrosis. Now, decreasing of fibrosis is very important, but the problem with obeticholic acid, it decreases the LDL levels, increases the LDL levels, decreases the HDL, causes pruritus, and there is some risk of jaundice in patient who is already having cirrhosis. So we have still an issues with obeticholic acid. So what do I do? And there can be still, the jury can be out on this, that if you have a non-diabetic patient, non-cirrhotic patient, of course, diet and drills, exercise and diet should be there in all patients. Maybe you can use vitamin E in non-diabetic, non-cirrhotic. In a non-diabetic and in cirrhosis, you can use vitamin E and maybe you can try obeticholic acid, but be very careful. His LDL levels rise can be there, and he may have some increase in jaundice, and when you have increase in jaundice, you have to stop it. In a patient who is diabetic and non-cirrhotic, which is the common population we get, or NASH with the fatty liver, you can use seraglutazar, and you can use SGL2 inhibitors. So these are the very true drugs which can be used in patients with diabetic fatty liver. And a diabetic who is already developed a cirrhosis, maybe SGL2 inhibitors will be a good choice, but the problem with SGL2 inhibitors in this group is UTI. SGL2 inhibitors have an increased tendency for urinary tract infections, and a cirrhotic is already compromised. So you have to be careful about UTI. GLP analogs can also be used in this group. They are not harmful. And of course, seraglutazar. I thank you all. I think I finished on time, and if you have any questions, we can take it.
Any questions? Please speak in the mic.
FibroScan. Role of FibroScan in
FibroScan is actually did not cover FibroScan because FibroScan is excellent to pick up both the fibrosis and now the degree of fatty liver. So ideally, all the patients who are having any findings of metabolic syndrome, diabetes, hypertension, IHD, you should have FibroScan. It helps in picking up the degree of fibrosis and the degree of fatty liver. But clinically, you can take a call. Any patient who has a waist circumference, the very easiest way of diagnosing the metabolic syndrome is the waist circumference. If the waist circumference is more than half the height, so if your height is 66 inches, and if your waist circumference is more than 33 inches, you are having metabolic syndrome. So your waist circumference should be less than 50% of your height. Normal height of the Indians is 66 inches or 67 inches. So our waist circumference should always be less than 33.5 inches. Very easiest way of diagnosing any forms of NASH, waist circumference. No need for FibroScans, no need for sonographies. A waist circumference is a very, so you should incorporate waist circumference measurements in all your patients, just like blood pressure measurements.
So I want to ask, what is middle age? Anyone? Middle age?
Middle age? Anybody? Okay. It's the age when the most of the people grow from middle.
Hello, sir. Sir,
So, dear friends, do you know that in the era of different new normals, sitting is the new smoking? So what we will do is, we will stand up and clap for the speaker so that we beat hazards of sitting and thereby new smoking.
Actually, to go further on this, I'll say sugar is the new cocaine. I'll just, that is how I explain to my patients. 50 years back, smoking was considered acceptable, and now we know how smoking is. Maybe 50 years from now, people will say, used to take sugar. So sugar should be the new cocaine. So we have to stop sugar if you want to take care of your health.
So thank you so much, Dr. Ashish Sethi sir, for the new knowledge and for your enlightening talk. Now I welcome Dr. Ashish Sethi sir down the stage for the felicitation. I request Dr. Jasmine Jasani to present the memento to Dr. Ashish Sethi sir. Now I welcome Dr. Chirag Seth, a police inspector of heart who can avoid your Hriday's Giraftari. I welcome him on the stage for his talk on 3D imaging of coronary atherosclerosis and its importance in cardiac care. And I request one of the chairperson to introduce Dr. Chirag Seth.
Good morning all. According to me, Dr. Chirag Seth for Barodians doesn't require any introduction, but still he is a senior and most popular interventional cardiologist and founder, director of Rhythm Heart Institute, Vadodara. He pursued training in cardiac electrophysiology and pacing for arrhythmic disorders at the prestigious Ascot Heart Institute, New Delhi. And he is a director, Department of Cardiac Catheterization and Intervention. Thank you. And I request Dr. Chirag Bhai to start the lecture.
Good morning, everyone. At the outset, let me congratulate Dr. Mitesh, Dr. Mehul, Dr. Neeraj, and the entire team for such an elaborate and exhaustive program, which is really interesting, and for nicely organizing this meeting. And it's really indeed a pleasure to be here at this morning. So quickly going on to my topic, the 3D imaging of the atherosclerosis and its importance in cardiac care. 3D imaging is now in vogue in a lot of other specialties, right? But my aim for this talk is to introduce how it has revolutionized the treatment in cardiac patients. So we know atherosclerosis, simply this image is from our pathology textbooks, that LDL cholesterol is imbibed across the intimal layer into subintimal space. Then oxidized LDL gets accumulated over there. Then the macrophages, they imbibe this oxidized LDL, they form the foam cells. Thereafter, there is migration of smooth muscle cells in the intimal space, and this is how a plaque starts developing and atherosclerosis progresses. And as we know, atherosclerosis is an age-dependent phenomena, and none of us are immune to it. We all are going to have it at some stage in our life. So it's universal. So when does this atherosclerosis become clinically relevant? So first is when it progresses to significant stenosis in the arteries which supply blood to the heart, causing angina. When the plaque ruptures and causes thrombosis leading to acute myocardial infarction. And of course, when these two modalities, these two presentations of atherosclerosis which are so lethal, our emphasis should be on preventive strategies as well as therapeutic strategies. So one important concept that we should know about how coronaries react to stenosis is this, that whenever the plaque develops, the nature wants to maintain the lumen of the artery so that enough amount of blood can still flow despite occlusion being developed. And that's why coronaries develop a positive remodeling, meaning thereby they grow in size to maintain a lumen so that you don't have symptoms, you don't have problems. And beyond 40% of plaque development, it starts gradually encroaching upon the lumen. And as soon as your plaque burden is 60% and more, you might start having symptoms of angina. So coronaries at times develop this positive remodeling to maintain the lumen, and therefore for any symptom, when you tend to see an angiogram might be looking relatively normal, but still that patient may have substantial plaque burden, and there comes the limitation of routine angiogram in patients with heart disease. And as we know, with increasing plaque burden, there can be rupture, and that invites platelet and the WBC adhesions to this, and that leads to clot formation. So this is, in brief, a normal artery, how it looks. Will look like this. It looks like a 3-layer structure with a high brightness. which corresponds to intima. Surrounding dark layer, which you can see in the gray image, which is a dark line is media and outside is adventitia. In this image, a brighter structure looks like intima, a dark thin line is media and outside is adventitia. So this is how a 3-layer artery structure normally looks. And this is how it normally has a structure. Intima is like a sponge, media is like a soft rope, and adventitia is like a mesh. And whenever the plaque develops, you can see this is a normal structure, and this is how a plaque develops, and that leads to a fibrosis in the intimal space. You can see thickening of the intima. So this is how intimal fibrosis looks. When the plaque is having a significant lipid content, it looks like this. It looks like murky waters. You see a dark space here in the subintimal space, which is lipid. So this is all lipid. Whereas if the plaque develops significant calcification, it looks like islands. This is an island of calcification, which starts from almost 10 o'clock position to almost 5 o'clock position. So this is significant calcification in the atherosclerotic plaque. So this is a lipid-rich plaque, and this is a calcific plaque. The plaque is covered by, if it is covered by a thin layer of intima, it is called a thin cap fibroatheroma. Here, the intimal covering is thin. It is a thin cap fibroatheroma. When it is covered with a thick layer, it is called a thick cap fibroatheroma. And as we know, if you have a thin cap fibroatheroma, they are likely to rupture easily, causing acute myocardial infarction. Plaque is developing mainly because of cholesterol crystals, and these also can be seen very well. This is cholesterol crystal, and this is how the collection of macrophages look in the plaque. And this slide shows which are the features of vulnerable plaque which can rupture and lead to acute MI. So if you have a thin cap fibroatheroma, this plaque can rupture easily. A lipid-rich plaque can rupture easily. If you have microchannels in the plaque, which indicates there is increased vascularity in the plaque, bringing in inflammatory cells into the plaque, it can rupture easily. If you have macrophages, if you have a spotty calcium, and if you have a cholesterol crystal, this indicates all features of vulnerable plaque, making the patients vulnerable to development of plaque rupture and acute myocardial infarction. And this is how actually a plaque rupture looks. You can see that the layer of intima has broken here, and here a white thrombus has started forming. So this is how a plaque rupture looks, right? With the plaque rupture, you can have different types of thrombus formation. If you have a thrombus which is very rich in fibrin, it will look like a red thrombus, and if it is rich in platelets, it would look like a white thrombus. So these are the two types of thrombus which can also be seen very easily. And this is how typically young patients with a history of smoking developing acute MI develop endothelial erosion. This is an erosion of endothelium leading to platelet aggregation here and leading to acute myocardial infarction. So this is the pathology called endothelial erosion. So all these images, how these images are acquired? These images are acquired, 3D images of this atherosclerotic lesions is acquired by these two modalities. One of the modalities is called optical coherence tomography. Here the picture is of arterial structure derived from optical coherence tomography. And the second modality is, which is seen in the gray scale, is intravascular ultrasound, which is IVUS. So what is intravascular OCT? OCT is an imaging modality that uses near infrared light for high resolution imaging of the vessel anatomy, tissue microstructure and stents. The key features are that it uses light and not sound. It does not use X-ray. Image acquisition is very fast, and images are acquired very sharp, detailed, and easy to interpret. Basically, it's a flexible fiber optic catheter which is used for light delivery. Infrared light is delivered inside the coronary. Fiber rotates to create images, and it is pulled back to map the vessel segment. More the frames or high frame density, higher the resolution, and this is how the images are created. So how do we perform angioplasty as of now today with the help of imaging? So this is a typical cath lab suite screen where we have integration of everything on the screen. You have here intravascular imaging, here you have fluoroscopic imaging, and here you have optical coherence tomography live, which can be displayed while performing angioplasty on a given patient. So we have integration of 2D imaging with the help of routine angiography with fluoroscopy, and we have 3D imaging assistance with the help of either intravascular ultrasound or optical coherence tomography on screen, so that we can integrate what we see on fluoroscopy as well as on intravascular imaging with the help of either OCT or image guidance with IVUS. So how actually we do it? So image is displayed in this fashion. You can have a B mode, which shows a cross section of the artery, and you can have L mode, that is longitudinal section of the artery. You can have both the modes available on screen, which can give you frame by frame, segment by segment details of the anatomy that you see, and the segments and details of atherosclerosis in that particular segment. So typically, let us say if you have acquired a run of OCT, we go frame by frame and select out what are the types of diseases that we are encountering in that given segment of atherosclerosis. So let us say this is a proximal to distal scanning, and this shows actual luminogram on 3D imaging. So this is a luminogram. We select out which are the areas which have largest lumen. The areas with largest lumen are likely to have less plaque burden. We start from assessing there. And what we find out is what are the healthy zones. Healthy zones are demarcated by 3 typical layers of intima, media, and adventitia without any plaque burden. So this is a normal layer. And on the other end, this is again a normal layer. Between these 2 normal segments, the middle 4 images show that there is a plaque. So normal to normal segment should be our target for treating a vessel, and in between what we find out are the details. So this is here where we see a fibrous plaque, here we can see a calcific plaque, here we can see plaque neovascularization, and here we can see a spotty calcium. So this is how the details, once you obtain, you understand the pathology that a given plaque consists of in a much more easier way. And why it is important? Because the plaque morphology decides how to treat. Not all types of lesions require simple balloon dilatations. If you have a very lipid-rich plaque, at times you avoid high-pressure balloon dilatation. If you have heavily calcific plaque, you need cutting balloons, balloons which have a blade over the surface. You require cutting balloon or special methods like rotablation. And if you have a heavily lipidic plaque, again you try to avoid high pressure balloon dilatation so that you don't develop no flow phenomena or slow reflow phenomena. So morphology is important as far as choosing how to treat that particular plaque. This also helps us to find out how to deploy a coronary stent in a given artery. Because fluoroscopy, as we know, is not the right tool always to find out normal zones. Because as we saw in an earlier discussion, that artery lumen may look normal on coronary angiogram despite a significant plaque burden. And that's why in high risk situations like diabetic or those patients with LV dysfunction or those patients who have diffuse disease, it is a good tool to find out what the job that we are doing, is it perfect or not. And the stent should start and end in a normal to normal segment. If your stents do not start or end in the normal segment, you are still likely to have failure of the stent, and it may lead to instant restenosis. And this is where the role of imaging is important, that you happen to find out and do your job more perfectly for better outcomes in long term for given patient. So this is one such example of heavily calcified coronary artery. You can see here the islands of coronary calcium starting from almost 12 o'clock position. You have a heavily calcific plaque all around, concentric heavy calcification. And this kind of calcific lesions, at times they don't open up very well with the balloon. And if you stent these lesions, these patients are not likely to have good long-term outcome, because if the stents don't open up well, if the lumen is not opening up well, the lesion will have restenosis even despite stent implantation. So what do we need to do? This calcium needs to be broken. Now we know about the role of lithotripsy in treating urinary calcium, right? The similar lithotripsy is now available for treating coronary calcium. Ultrasound waves can be applied with the help of balloon at the site of lesion, and these ultrasound waves, they can break this coronary calcium. It is called a method of intravascular lithotripsy. So this is an image, a 3D image derived from OCT showing this kind of pathology. So you can see how the coronary calcium was seen here all around, and this is how the calcium has been broken with the help of intravascular lithotripsy. So this is where the utility of imaging is, and it shows how successfully this kind of complex lesion can be treated. If you don't have imaging, you are bound to have failure of treating this patient with a routine angioplasty. Routine tools probably will not work for this kind of blocks. So this is how after angioplasty the imaging would look. That you can see a stent in longitudinal section, you can see a stent in as if you're traveling from in a 3D navigation mode, as if you're traveling from the vessel, and you can see simultaneously in the cross-sectional image. So this is almost like a live image, as if you're traveling from within the artery. It can show how your stent has been deployed and how the stent result is, right? And the AI-based system shows us whether the stent result is good or not. If your stent studs are looking white, that means stent is very well apposed to the vessel wall. If your stent studs are looking red or yellow, that means stent is not well apposed to the wall. So all these features you will not always be able to see on a routine fluoroscopy or routine angiography, but this system will show you that whether your job is perfect or not. And whenever you find this, you still need to do a job better. You need to further balloon dilate with high pressure balloons or higher sized balloons so that all studs look white and the result looks good. So this is what the impact of imaging is, that you can reduce your chance of stent failure by paying more attention to these details which are seen on 3D imaging. And this is how your rendered stent image shows that once you have deployed the stent, it is symmetrically expanded or not, whether it is very well deployed or not. You can see here, the red dots here show here that the stent is not opposed to the vessel wall very well. If you do just angiogram, you won't be able to realize that stent in this area is not very well opposed to the vessel wall. And this is the site where stent thrombosis can occur. So this is whenever you see on a 3D imaging, you tend to improve it. You do high pressure balloon dilatation and further see to it that the stent is opposed to the vessel wall very well. This is one such example. The stent studs were not opposed very well to the vessel wall, and this patient developed instant restenosis. You can see stent studs as the bright structure here, and you can see a bright structure between the lumen and the stent studs, which is showing significant instant restenosis because of intimal fibrosis. So if this job has been done in index angioplasty well, probably instant restenosis could have been prevented. There are other causes of stent thrombosis in the form of stentage dissection and stent malapposition, which also can be easily detected by 3D imaging, and it can be prevented in the index procedure so that the patient does not have major adverse coronary events in the future follow-ups. This is one such important aspect, the under expansion of the stent. The system shows how your stent is expanded well or not. Normally we say that the stent should be expanding more than 80%. The system shows that here your stent is not expanded well, it is just 53%. Versus here in this example, it is almost here 85% or 111%. So you have to target your stents to expand more than 85%. And this you can only know with the help of 3D imaging, right? So at the end, let me just conclude my talk by saying what is the clinical impact of 3D imaging on angioplasty as of now. So it adds to technical perfection in treating coronary stenosis with angioplasty. It adds to safety and procedural success because you now not only know 2D aspects of that atherosclerotic lesion, but you know 3D aspect. You know actually the vessel size, you know plaque morphology, you know how to treat them and how to prevent the complication. And that's how it adds to safety. It translates into lower risk of stent failures and the need for repeat procedures. And definitely it has shown in multiple clinical trials over the last 2 decades that it has got better long-term outcomes and better survival. So as of today, what are the indications of 3D imaging with OCT or IVUS? It should be recommended in patients undergoing angioplasty if they have these indications: acute coronary syndrome, if you have a diffuse calcific disease which requires multivessel angioplasty, if you have a left main disease which is undergoing treatment with angioplasty as an option, as an alternative to CABG. If you have a proximal LED disease, definitely yes. If you have a bifurcation stenosis, and if you have instant restenosis or any stent failure for that matter. So all these indications demand that if you do 3D imaging to assist your angioplasty, the outcomes are going to be better. And if you don't, I mean, yes, your chance of MACE rates, major adverse coronary events, are going to be high. Complex patient characteristics, that is diabetes, renal impairment, and LV dysfunction, these are also important indications wherein imaging should be considered. Thank you for the patient hearing.
One important announcement, those whoever has come with their spouse, for them we have organized one interesting activity outside this hall. They can proceed there. Now again, I request everyone to stand up and clap loudly for the speaker, for his wonderful speech.
Thank you.
Thank you, sir, for sharing your vast knowledge. Now I welcome now I welcome you down the stage for the felicitation, for which I request Dr. Ketan Shah sir to present the memento to sir.
And I also welcome all the chairpersons down the stage for the felicitation. And for the same, I request our own President, Dr. Mitesh Shah sir, Dr. Mehul Desai sahib, and Dr. Pragnesh Shah to give memento to our chairpersons.
Now we have a panel discussion on clots, coagulation, and paradigm in lungs, multidisciplinary discussion. I welcome the panelists on the stage, for which Dr. Kamaldeep Chawla sir, who is a senior consultant interventional cardiologist, Dr. Parth Solanki sir, who is consultant cardiovascular and thoracic surgeon, Dr. Amit Dave sir, consultant pulmonologist, and moderator Dr. Neil Thakkar sir, who is consultant pulmonologist. Dr. Neil Thakkar sir will moderate the session, and over to Neil Thakkar sir. Now I request you to introduce all panelists in 4 to 5 lines.
A very good morning to all the respected seniors, friends and colleagues in the Indian Medical Association, Vadodara. We are all here to discuss regarding clots, coagulations and paradigms in the lungs. Again, we have a panel entirely from Sterling Hospitals. We have our consultant interventional cardiologist and head of department cardiology, Dr. Kamaldeep Chawla, Dr. Amit Dave, consultant interventional pulmonologist, Dr. Parth Solanki, our cardiothoracic surgeon, and myself, Dr. Neil Thakkar. I am a consultant pulmonary and critical care physician. So again, what we'll be discussing today is mostly to do regarding clots, coagulation, and the various aspects of clotting in the lungs. So starting off with the case. So this is a case of a 47-year-old male. He's a non-smoker. He has an office job, is vaccinated. He's obese, is hypertensive, and less mobile since a few months. He doesn't have any other comorbid illness. He has breathlessness at rest with an MMRC scale of 4. Since the last 2 to 3 days, more increase since 1 day, chest heaviness and fatigue, no history of fever or cough, no orthopnea or paroxysmal nocturnal dyspnea. His pulse rate is around 128, blood pressure of around 100/60, saturation around 82% at room air, which comes to 96% with 4 liters on nasal prongs. Breath sounds are diminished, few crepitations and bilateral basal rhonchi are present on examination. This is just a introduction of a baseline case. We'll carry the panel and the case parallelly so that we can have a fruitful discussion. So again, the first question to the panel, in your practice, what are the most common 3 scenarios where you would suspect or you have encountered a patient of pulmonary embolism? This question will go to Dr. Kamaldeep Chawla.
Yeah, good morning friends. First of all, Neil, you relax. Bahut time hai. Don't worry about the time. So, we can ask anybody, what do you think this case, what are we going to discuss? So anybody wants to guess? So a patient with some risk factors comes with hypoxemia of severe onset. So we do a brain run, what we are going to deal with this patient. Now, Neil has already given us the diagnosis that what we are going to discuss is pulmonary embolism. So the first thing that comes to our mind in pulmonary embolism is the Furco's triad, which all of us, I think, ratified in our MBBS days. So Furco's triad is basically some damage to the veins, stasis, and a hypercoagulable state. Beyond this, as a clinician, what I have encountered in my practice about the 3 common causes is I have seen more females who are on oral contraceptive pills. So very important for our primary care physicians to keep in mind in that particular clinical scenario. Second is an orthopedic patient. So post-operative patient who has been in bed or for a long time. So the stasis, from Furco's trial. And third common patients we see is unidentified causes that I have seen. So I have not seen many cancer patients coming as a hypercoagulable state, but without any reason, and then we don't work up. And I think all of us agree that in our clinical practice, whatever pulmonary embolism we have seen, usually we are not able to identify the cause. So over to Amit.
Thank you. The same question follows to Dr. Amit Dave. What are the most common 3 scenarios you have seen?
So, good morning, friends. I do agree with Kamal sir that oral contraceptives is a far benign common causes of pulmonary embolism and obesity, as he mentioned, morbidity. But in being an intervention pulmonology and now growing literature is saying malignant processes we are seeing a lot of nowadays. So in my practice, I do see more malignancy patient who is coming with a pulmonary embolism, and it is a biggest factor, risk factor for any pulmonary embolism patient. He talked about unidentified cases. I do have seen many unidentified pulmonary embolism ultimately turn out to be a occult malignancy. So in my practice, first is malignancy. Second, I do frequently see, I agree with post-major surgery like orthopedic surgeries or any long surgery who has been more than 4 hours or 5 hours. Those stasis occurs in the vein, DVT happens and pulmonary embolism occurs. Third, I should not forget this grave pandemic, the post-COVID scenario, and COVID itself is a thromboembolic disease. And so many patients, me and our critical care colleague have faced this pulmonary embolism in COVID scenario. So recently, these 3, I think, most common causes we have seen in pulmonary embolism. Thank you.
Thank you. And the third question again goes to the cardiothoracic surgeon. Most common 3 scenarios, and what according to you is chronic pulmonary thromboembolic disease, and what symptoms do you find in your patients that present with the same?
The most common symptom, most common scenario according to me and in my clinical practice, I will first say patients of deep vein thrombosis. Patients of deep vein thrombosis are prone to develop thromboembolism, acute as well as chronic, in 1 to 5% of cases. Second is any hypercoagulable state. The most common state, hypercoagulable state, which I have encountered in my clinical practice is pregnancy. Post-pregnancy, many of the patients develop DVT and then later on develop pulmonary embolism. And the role of oral contraceptive is also much more, as is been written in books. It is much more. Those patients develop, they tend to develop, have more chances of developing pulmonary embolism. First they develop DVT and later on develop pulmonary embolism.
Thank you, sir. So again, moving forward, this question will go to Dr. Amit Dave. So what?
Can I just explain chronic?
Yes, please.
See, now chronic pulmonary thromboembolic disease. There are 2 phases of thromboembolism. One is acute and another is chronic. Chronic thromboembolism develops from acute thromboembolism where there is a single attack or recurrent attacks of acute pulmonary embolism, which further causes activation of the coagulation cascade, as Dr. Kamaldeep sir had mentioned, which leads to development of fibrin, platelet activation, and this further leads to intimal hyperplasia as well as medial hyperplasia of the pulmonary arteries. This is the cause of chronic pulmonary thromboembolism. Now, what are its symptoms? Symptoms, as sir has mentioned, the most common symptom is dyspnea, dyspnea at rest, dyspnea on exertion. The most common symptom is breathlessness. Patient comes with breathlessness to us. And most of my patients are bedridden, patient having long ventilatory stay, patient having long post-operative stay, patient who has suffered from DVT previously.
Thank you for the enlightening on all the features regarding chronic pulmonary embolism. The next question is to Dr. Amit Dave. What are the clinical ways to predict the probability of pulmonary embolism or ruling it out? And more importantly, as we all see in the era of the pandemic, that D-dimer is a very repeated investigation which all of us face when we see any patients coming with reports. So what do you think, how important is D-dimer in this clinical background?
Thank you, Nidhi. Very good question, I would say. Pulmonary embolism, any disease, any acute condition, as sir has mentioned, this can be acute and chronic. So any acute scenario patient is coming with hypoxemic, severe hypotensions and all that, you need to suspect pulmonary embolism with severe hemodynamic failure. So clinical probability, there are a few scores like Well score, Medify scores, NSI scores. These are the risk factor, combinations of risk factor, clinical, your judgment, hemodynamics, and at the most 2D echocardiography, which can be done on a bedside. So on the basis, the mild, moderate and severe predictability can be taken care of. Symptomatology, risk factors, and prevent major surgery or a malignant process in past history. So all those scores are very well written on the website. I am not going to is in detail in that, but I would like to mention regarding D-dimer. In COVID pandemic, we have done exclusively do a D-dimer. D-dimer is basic acute phase reactant which happens due to hypercoagulability in our body. So when we are suspecting pulmonary embolism, if D-dimer is high, per se in thousands or many thousand, but your clinical predictability or clinical suspicion is not too high. So D-dimer is just to rule out pulmonary embolism. Suppose pulmonary embolism patient, you are suspecting pulmonary embolism, but D-dimer is normal, so it's practically rule out the pulmonary embolism. So importance of D-dimer according to me is to predict a negative predictive value to ruling out pulmonary embolism rather than to diagnose a pulmonary embolism. And I would say repeatedly test of D-dimer is not mandatory. CT pulmonary angio nowadays, awareness regarding CT is more due to thanks to COVID era. So CT pulmonary angio is a far most gold standard if your predictability is stronger or high. Kamal sir, I think you...
Yeah, I want to add that there are two clinical tests which are of real importance, especially in the scoring system. One is troponin and anti-pro-BNP. They are more important than D-dimer if you want to really label that you are heading towards diagnosing pulmonary embolism.
Very rightly mentioned by Dr. Kamaldeep Chawla. So again, when we label a patient with massive or submassive embolism, RV dysfunction is important. So troponin I, anti-pro-BNP both are important for RV dysfunction. Now to elicit the scores, there is the Wells or the modified Wells, the modified Geneva score, pulmonary embolism rule out criteria and D-dimer. 4 tests we can use. I won't go into the individual ones, but symptoms of DVT, some vitals such as heart rate more than 100, history of hemoptysis or malignancy, these all weigh out more on the Wells criteria as well as the modified Wells criteria. Modified Geneva score also has these risk factors. Pulmonary embolism rule out criteria has age less than 50, no tachycardia, no hemoptysis, no history of OC pills, no prior DVT. Now again, based as Dr. Amit Dave mentioned regarding D-dimer, so if there's a low probability of pulmonary embolism and the pulmonary rule out criteria we have applied and we feel that okay, there is, it is not ruled out that this patient is not likely to have pulmonary embolism, there comes the role of a D-dimer. So again, very important negative predictive value rather than positive. Now going forward, what are the more common presentations on ECG and echocardiography? This goes to Dr. Kamaldeep Chawla. Which are the presentations on ECG and echo when you suspect the patient having pulmonary embolism?
Obviously, this has to come to me. I know. I mean, yes. Amit wants to answer that question. Okay.
You are the best judge.
I just want to tell the audience that he only told us the case. He has not told us the questions what he's going to ask. So ECG wise, you know, all of us are in big myth, but the first important or more sensitive thing is sinus tachycardia in a case of pulmonary embolism, and its sensitivity is only 44%. Next important is incomplete RBBB and right axis deviation, and that too the sensitivity comes to around 25%. The very famous S1Q3T3 pattern, you know, we keep it in mind. And are you showing that, Neil, over there?
Yes.
So in lead 1 there is a S wave, and in lead 3 there is a Q wave with T wave changes. That's a classical S1Q3T3 pattern. All of you can keep it in mind. Though as per literature, its sensitivity is only 20%. It's also called McGinn white sign. But in clinical practice, we have seen that this is an important sign to keep in mind. Echo-wise, right ventricular RARV dilatation, right ventricular volume overload, and increase in pulmonary artery pressures as diagnosed by the Doppler. Usually in acute cases, the PA pressures are around 50 or less than 50. And more than 50, usually the case is a case of chronic pulmonary thromboembolism. So these are the ECG and echo findings in a typical case.
So again, just like Dr. Kamaldeep Chawla has mentioned, this is a patient with the echo showing RARV dilation, and we see that there is collapse of the left side and dilation of the right-hearted chambers, as well as increased in the right ventricular pressures. So this was the presentation in our particular patient. The patient had a S1 Q3 T3 pattern on the ECG, dilated RARV with increased right heart pressures. So again, coming to the next question, what are the important signs on radiology and what is the modality of choice? I think modality of choice Dr. Dave has already discussed regarding a CT pulmonary angiography. So what are the important signs on radiology that you see in a pulmonary embolism?
So if we talk about signs, so radiology has a vast science and they have been already proven in majority of the cases. They called as a Westermark signs, Hampton hump, and many more signs. But as I mentioned, the gold standard is CT pulmonary angiography. The most 100% sensitivity, I would say, and specificity is a CT pulmonary angio, and the classical sign is filling defect in pulmonary vessels. So according to me, filling defect, if you have a, can we run this? So filling defect sign in pulmonary artery is 100% sensitive and specific for pulmonary embolism. Apart from this, we can see Hampton hump, that clotted vessels give a rise of hump-like structure in lung parenchyma. Infarct, lung infarct can be seen, and Westermark sign. So these are the usually radiological signs which we see, and as I mentioned, CT pulmonary angio is a gold standard.
So again, here we see the main pulmonary artery and its bifurcation. So in our particular case, there was a saddle thrombus. As we can see that white is the main artery, and in that we see a filling defect right at its bifurcation, and it is continuing into bilateral main pulmonary arteries. Hampton's hump is again because of a pulmonary infarct, as Dr. Dave has mentioned. This is a infarct which is seen, and that is giving rise to a hump-like appearance on the X-ray and seen in radiology. Westermark sign is pulmonary oligemia, again which is seen on the left side lower lobe, where we see it is relatively oligemic compared to the rest of the fields. That is again due to the embolism in the left pulmonary artery. So again, going forward in our case, the patient, these are the lab reports. Coagulation profile was okay. TROPI 0.043, D-dimer more than 4,000, NT-proBNP 8,890, renal function test was okay.
I just want to tell the audience that these markers are signs of actually RV ischemia. Right ventricle is getting ischemic, like in MI, left ventricle is getting ischemic because of pulmonary pressure overload. So that is why these enzymes are elevated.
So again, based on this, after this, the patient was hypotensive, had a, majority of this evaluation was done in the ER itself. After admission, patient was admitted in the ICU, given IV fluids with IVC as well as clinical assessment, oxygen support, urgency discussed with the family, risks of bleeding explained, and patient was planned for thrombolysis with alteplase. So now coming to thrombolysis, what are the most important signs, things we keep in mind when we decide upon thrombolysis, and which is the agent of choice and absolute contraindications? This question is for Dr. Kamaldeep Chawla.
So before thrombolysis, as for any other thrombolysis, we have absolute contraindications like a neurosurgery done in previously, or an intracranial tumor which has been there, or an active bleeding other than a menstrual cycle. These are absolute contraindications. We should also keep in mind some relative contraindications like blood pressure more than 180. We should try to avoid at that time, bring it down, and then go for thrombolysis. The molecule of choice, as per literature and evidence, is alteplase. We get it by brand name of Actelize. But I think majority of us clinicians, even in the audience, have used many other molecules, used retiplase, etc., available in our setup. But by evidence, the molecule of choice is Actelize, which is given over a 2-hour infusion.
And again, one important thing that before, as already we have mentioned regarding the molecule, as well as we rule out the contraindications, before thrombolysis, we, if possible, if a patient is not on blood thinner, we should send a thrombophilia profile. That will help us in ruling out any hypercoagulable state in a later run, and monitor vitals when neuromonitoring after. So again, indication and potential indication of RV dysfunction we have discussed. So going forward, alteplase 100 milligram administered over 2 hours is approved by the US FDA. And this was the patient's pre as well as post thrombolysis echo, where we found that the RARV, which was dilated, now again it has gradually come back, the pressures have come back to reduced compared to earlier. Again, the CTPA was also repeated, which showed that majority of the thrombus burden in the main pulmonary artery had reduced. This was on day 4 post the thrombolysis. Further course, no DVT. We found that the patient had antithrombin 3 deficiency, which was likely the cause for a hypercoagulable state. Oxygen was tapered off and patient was shifted to rivaroxaban. Now again, what the next question is to Dr. Parth Solanki, what are the surgical options in chronic pulmonary embolism, indications of endarterectomy, and what is your approach to this procedure?
In case of chronic pulmonary thromboembolism, the surgical treatment which we have available is pulmonary thromboendarterectomy. See, here we can see the picture of the atheroma which has been cleared out from the pulmonary arteries. The second picture, it shows us we have opened the pulmonary artery and we can see the patent lumen and the obstructed lumen, and the atheroma or the debris is being removed from the pulmonary artery. Now a short and brief explanation of the procedure. In order to open the pulmonary artery, we have to put heart on cardiopulmonary bypass machine. We have to arrest the heart and lower the temperature of the body, and we have to go under total circulatory arrest. The temperature of the body should be 12 to 14 degree nasopharyngeal temperature, and a stage of circulatory arrest is being established for 15 to 20 minutes, and the pulmonary artery is being opened. It is being opened up to the level of the lobar arteries. If right and left both are involved, then both are being opened separately. Next question.
So again, just take 2 more minutes of the time, 2 extra minutes. So again, what are the novel interventional techniques that is used for management of pulmonary embolism in the cath lab? This question goes to Dr. Kamaldeep Chawla.
Okay, so before answering and going to the novel techniques, I think we should still stick to the thrombolysis as the first modality of choice, because that is available at primary care, secondary care, tertiary care. Novel techniques are catheter-directed thrombolysis. So you put a catheter in pulmonary artery and run the thrombolysis over there. Good results with that. Main indication for the novel technique is a highly unstable patient. And this is something what we recently did in Vadodara, and first case reported in India because we did it through the jugular approach. So this is a penumbra device wherein we put in the device and suction all the clots from right pulmonary artery, left pulmonary artery. This is our index case, our first experience, and I think we should promote this technology more, not very costly as well. And our patient had a glioblastoma removed 6 months back, and he already had massive DVT. Both his femorals were blocked with thrombus, and this is just a picture of what we removed. We removed almost 100 times more clot than this in the cath lab. And patient's PA pressures came down from 85 to 54 within an hour of the procedure, and we discharged him at 4th day, a doctor's relative. So this is something new, available. All cath labs in Baroda are capable of doing it. Only we have to begin the procedure. Thank you.
The last question for the panel. If a patient has a massive hemoptysis, again we've discussed other paradigms besides clotting. If a patient has hemoptysis or acute bleeding, what are any novel interventions in the interventional pulmonology suite? This question is for Dr. Amit Dave.
So if patient is coming with massive hemoptysis to us, so basically we try to hemodynamically stable first. Once hemodynamically stable patient and still on ventilator patient is bleeding, we need to check the airways. And such a case that I have to see the airways, and it was a huge mass bleeding tendency, huge vessels. If you see right corner first picture, that bleeding mass. So I had to intubate him with a rigid bronchoscope, do a cold therapy called as a cryo extraction of mass debris, and then a hot therapy, and evacuate entire mass and debulk the mass in the airway to stop the bleeding. So patient extubated 3rd day and went discharged home. So these are the very rare procedure can be done in the case of if patient is not settled with conventional methods of stopping blood. Very risky procedure. It has to be done in controlled and well environment, interventional pulmonologist suit. It requires a hot as well as cold therapy called as a endobronchial cautery and endobronchial cryotherapy. So this was the picture post operation, and it took me almost 4 hours to debulk this mass and cauterize the main carina. Thank you.
Thank you so much. And again, take home messages for any massive embolism. Time is tissue. The earlier we thrombolize, the better the chances that the patient will improve hemodynamically and settle. Teamwork is the dream work. You need a multidisciplinary approach. The ER team, nursing staff, radiology, echo technicians, all the specialists involved. It is not a single person approach. Pre-test probability scores can help determine the risk. Echo is a powerful tool to diagnose, detect and prognosticate. Timely diagnosis and early management makes the difference. There are novel interventions as well as newer solutions, and surgery has a vital role in management of chronic pulmonary thromboembolism. Thank you so much. This was Rudolf Virchow. So belief begins where science leaves off and ends where science begins. Thank you so much for your time.
Thank you. Any questions?
Any questions from the audience?
Friends, you know that we all sit down a lot. As per one fact, we sit for nearly 12 hours during weekdays out of our 24 hours and 8 hours in weekends. Isn't it a lot? So I request everyone to please stand up and clap loudly. Thank you all the panelists and our speaker Dr. Neil Thakkar for sharing the latest knowledge of the field, and I am sure everyone have enjoyed it. Now I welcome all the panelists and speakers down the stage, and for felicitation of them, I request Dr. Mayur Adalaja, Dean GMERS Gotri, Dr. Satish Pandya, very senior pediatrician of Baroda, Dr. Jagdish Patel and Dr. VC Chauhan to present the memento to our panelists. Friends, to chair the next sessions, I invite Dr. Ashutosh Singh Rathore and Dr. Dainik Savani on the stage. Dr. Dainik Savani sir is a senior insurance medical officer ESIS Gotri Vadodara, and Dr. Ashutosh Singh Rathore is a practicing pediatrician and president of Academy of Pediatrics Vadodara. Come my friend, IMA Vadodara feel really proud to have the respectable both of you today. Now I welcome Dr. Revati Iyer Madam on the stage for her talk on facts and myths, do's and don'ts about the dreaded dengue. And I request the chairperson to introduce Dr. Revati Iyer Madam.
Dr. Revati Iyer ma'am is MD, DNB and IFCCM Edict Director of the Medical and Surgical ICU. She is the past president of ISCCM branch Baroda and national faculty in many workshops and conferences in India as well as abroad. She authored the chapter titled Advanced Medical Directives in India, the Ethical, Legal and Practical Aspects in Critical Care Update 2021, and also titled a chapter How to Mitigate Ill Effects of High Staff Attrition Rates in ICU in Critical Care Update 2022. Over to you, ma'am. Welcome on behalf of Academy, Indian Medical Association, Vadodara.
Should I start? Should I start? Because something is going on. Okay. Okay, I think the time is limited, so I should just hurry up. Just have 10 minutes to talk some nuggets on dengue, because this is what we is having. We've lost of young deaths in the recent epidemic. The general public and even some doctors feel that once you have dengue, you have a lifelong immunity. And I think that is a myth. The fact is that you can have dengue fever multiple times. Even my son had 3-4 times. And the second infection can be really fatal. So what works? There's a very interesting fact that dengue virus has 4 serotypes. then 1, 2, 3, and 4. And each serotype provides specific lifetime immunity and short-term cross immunity. All serotypes can cause severe and fatal disease. Genetic variation within serotypes, some appear to be more virulent and greater epidemic potential, but all of them can produce outbreaks and epidemics. There is an interesting finding which you can actually see in the lab reports, in which you can find out whether it's a primary or a secondary infection. In primary infection, the IgM antibodies appear in late acute or convalescent stage, and IgG which lasts for several decades. But while in a secondary infection, you will have very high IgG levels and a very small rise in IgM levels. So what happens is infection with one serotype does not protect against the other serotypes. On the contrary, a secondary infection with another serotype leads to something which is known as antibody-mediated enhancement, which in turn leads to release of cytokines and complement activation, leading to plasma leakage and DIC, which results in dengue hemorrhagic fever, which can be actually fatal. So there is an enhanced T cell activation in secondary infection, and this phenomenon is known as original antigenic sin. Second is there is always a, some you feel that all patients need hospitalization. Even stable patients walk in, they're scared. And sometimes patients feel that they can be treated at home. So what is the fact? Mild cases can be treated in outdoor basis with monitoring, and moderate and severe cases need hospitalization. So how do you determine that? So we need to know, we have good national guidelines 2015, which says symptomatic dengue is divided into mild, moderate and severe. Mild would be undifferentiated dengue fever without complication like bleeding, hypotension and organ involvement without any evidence of capillary leakage. These are patients who can be managed at home. And moderate again is divided into two. Dengue fever with high risk and comorbid conditions such as infants, old age, diabetes, hypertension, pregnancy, coronary artery disease, hemoglobinopathies, immunocompromised patients, patients on steroids for some reason, anticoagulants, those on warfarin, Novax, and immunosuppressants. Then second category is dengue fever with warning signs and symptoms such as those with recurrent vomiting, abdominal pain, tenderness, general weakness, letharginess, restlessness, mild pleural effusion, ascites, hepatomegaly, increased hematocrit of more than 20%. This is a very important finding one should note. Dengue hemorrhagic fever type 1 and 2 with minor bleeds. These are the patients who need very close monitoring and hospitalization because they can deteriorate anytime. Then comes the severe dengue, in which you have dengue fever or hemorrhagic fever with significant hemorrhage, with shock, grade 3 and dengue shock syndrome. Severe organ involvement, which we call expanded dengue syndrome, with CNS, liver, kidney involvement, etc. And severe metabolic disorder like acidosis, electrolyte imbalance. These are patients who should be managed in tertiary level care with good critical care backup setup. So that, like I had already described, dengue fever can be classified as simple one, fever with 2 or more symptoms, headache, retroabdominal pain, myalgia, arthralgia, leukopenia, occasions, thrombocytopenia, no plasma leak. Dengue hemorrhagic fever 1 with all above symptoms with a positive cornicate test, platelets less than 1 lakh, hematocrit rise more than 20%, grade 2 above with a spontaneous bleeding. Grade 3, some signs of circulatory failure, and grade 4 when there is profound shock with undetectable BP and pulse. These we should be knowing so that we know which patients should be taken seriously and which can be managed lightly. So tourniquet test procedure can be done in the, even at an OPD basis. Get a blood pressure cuff properly covering 2/3 of the arm and maintain it for 5 minutes with a mean blood pressure, that is systole plus diastole divided by 2. Check for petechiae using a 1:1 inch opening on a cardboard below the antecubital fossa. A positive tourniquet test means at least 20 petechiae per square inch. So like already discussed, dengue hemorrhagic fever, we've seen the WHO criteria: fever, hemorrhagic tendencies, positive tourniquet test, petechiae, ecchymosis, bleeding, thrombocytopenia less than 1 lakh, and evidence of plasma leakage, rise in hematocrit more than 20%. I'm repeating it again and again because this has to be monitored. There could be a drop in hematocrit, which means there is bleeding, pleural effusion, ascites, hypoproteinemia, And dengue shock when there is rapid weak pulse, narrow pulse pressure less than 20 before actually you have a shock. Cold clammy skin, restlessness can present with abdominal pain mistaken for acute abdominal emergency. So third thing is, should all patients be managed with oral hydration, or should all be given massive IV fluid transfusion to the extent that they land up in pulmonary edema for prolonged periods? So the fact is, calculated fluid therapy in moderate and severe dengue patients for only 48 hours is advised. Otherwise, we can land up in trouble. So in patients of dengue hemorrhagic fever in early stages, say in the febrile phase, that is when you have to closely monitor them for initial signs of shock. The critical period is during transmission from febrile to afebrile stage. That is when patient can deteriorate at about third day of illness. And then you should do serial hematocrit determinations, which can reflect the degree of plasma leakage and need for IV administration of fluids. And 1 and 2 is where you give IV fluid, crystalloids, till hematocrit improves for 24 to 48 hours with a monitoring of good urine output about 50 ml per hour. Blood component transfusions if patient is bleeding or hematocrit falls without clinical improvement. 3 and 4 critical case, you can have a compensated shock. This is a very important thing which may be easily missed by an inexperienced physician. Should have a very high index of suspicion because patient may be fully conscious, blood pressure may not be low. The only thing which you see is tachycardia and a narrow pulse pressure. Such patients should be managed in a critical care unit. 10 to 20 ml per kg per hour bolus fluid over 1 hour followed by infusion to achieve target hematocrit, optimal hemodynamics, good urine output for 24 to 48 hours, blood component transfusions, inotropes, and good critical care management and treatment of secondary infection is what is advised. In profound shock, those are the patients which actually come with a low or unrecordable BP, altered sensorium, irritable, agitated, seizures, liver kidney dysfunction, occult overt bleeding. They may have acidosis, calcium electrolyte imbalance, hyperglycemia. Hematocrit is very high, not responding to crystalloids. Colloids or other albumin especially may be added to crystalloids. No other colloids are advisable. If there is a fall in hematocrit with a persistent shock, occult bleeding should be considered, blood transfusion should be given, inotropes to maintain BP, renal replacement therapy and hepatic encephalopathy treatment should be done. So when to stop IV fluid therapy is very important. When patient is better, there is cessation of plasma leakage, BP pulse, peripheral perfusion is normal, hematocrit decreases, continuing IV fluid therapy beyond 48 hours can put the patient at risk of pulmonary edema. So two last slides. Platelet transfusion, when should we give platelet transfusion? Should every patient be given platelets? If platelets go down to 30,000, that's what happens in practice. Fact is, you may not need to give platelets even if the platelets goes less than 10,000 in the absence of bleeding manifestations. It may be given only when there is a prolonged shock, severely bleeding patients, coagulopathy, abnormal coagulation, massive systemic bleeding, along with red cell transfusions. Standard dose is 5 to 6 units of random platelets or 1 unit of apheresis platelets according to requirement. For neonates or infants, dose is 10 to 15 ml per kg of body weight. Because there are a lot of risk, non-hemolytic transfusion reaction, allergic reaction, sepsis, ALI, alloimmunization, refractoriness, edema and infection. So risk-benefit ratio should be assessed. Steroids, these are the very controversial subject. Almost all patients of dengue receive steroid for one reason or the other. To increase platelet count in case of thrombocytopenia, in all patients you suspect HLH if ferritin levels are high and you give steroids. And in shock, of course. So fact is, steroids should not be routinely used for thrombocytopenia unless it is prolonged and you proved ITP. No need to give steroids in every case of high ferritin unless you proved HLH by clinical and or bone marrow criteria. And according to randomized control trials, there may be some beneficial effects of steroid in the intermediate stage from the onset of critical phase to time before severe stage of dengue shock syndrome, but not actually during shock. Steroid abuse can actually predispose to secondary bacterial and fungal infections and should be avoided. My last slide, key points. The second or subsequent infection may be fatal because of cross-reactivity between the various dengue viral subtypes. So I'm actually scared when the patient says he's already had dengue once. Mild cases can be treated at home, but moderate and severe cases should be recognized and hospitalized for proper monitoring and treatment. Calculated fluid therapy in moderate and severe dengue for 48 hours is advised with hematocrit monitoring. overdose should not be there. Platelet transfusion in dengue should be reserved for those with severe thrombocytopenia with bleeding or in profound shock. Otherwise, it should not be given, and steroid use should be restricted to selected patients approved HLH or ITP and a controversial in DHF before progression to DSS. Abuse can lead to multiple secondary bacterial and fungal infections. Thank you.
Thank you, ma'am. Any question? Yeah.
A question regarding the classification. What you showed is probably an old one. Now in pediatrics, at least we follow the newer guidelines with probable diagnosis, with warning signs, without warning signs, and
This was with and without warning signs, sir.
Right. So
This classification.
DHF class 1 and all those things are not, they are obsolete according to our pediatric guidelines. Second thing I wanted to ask you was regarding the effect of COVID. Post-COVID, we have seen a lot of pediatric cases which will get very prolonged illness, like fever of even 2 weeks, 3 weeks duration, ruling out everything else. Have you found the same thing in adults?
No. We have had patients of COVID with dengue, combined infections, but we've not had patients with prolonged fever. No, I have not seen any such case.
We registered using steroids to suppress the immune reaction to COVID and prolonging the dengue. We used to give naproxen to some of the patients and they responded well. We did everything to rule out any other cause of fever, and this is across the country.
So in that case, I think if you have a second spike of fever, I think you rule out HLH.
Yeah, we did that.
Yeah.
We did that. This was simple fever just getting prolonged beyond, say, 10 days, 12 days also.
At least in adult practice, I have not seen anything, any such case. If any other physicians here have seen, then they can comment on it.
Thank you.
Thank you.
Hello. Yes, ma'am. Good morning. Very nice lecture. Ma'am, just one question that would the diuretic, any of the loop diuretics would help as non-reactant in means post-blood transfusion to the patient?
Did not follow your question.
Would any of the loop diuretics would act as non-reactant post-blood transfusion to the patient?
Loop diuretics?
Yeah.
Yeah, they can be given as per requirement. See, if you are going to give too many transfusions, you can end up in trally, you can end up in pulmonary edema. So, as per need, there is no recommendation.
Thank you.
Thank you. One more fact. From 1980 to 2000, there is an increase of 20% of our average sitting time. So friends, please stand up and clap loudly for ma'am. Thank you, Revati Iyer ma'am, for your short, sweet and crisp talk. Now I welcome you down the stage for felicitation.
Hello.
I request Dr. Ashutosh Singh Rathod sir to present the memento to ma'am. Now I welcome Dr. Ritesh Shah sir on the stage for his talk on myth and fact about fluid therapy and shock. I request the chairperson to introduce Ritesh Shah sir.
Dr. Ritesh Shah is a very well-known critical care physician and director of critical care unit at Sterling Hospital, Vadodara, with many academic achievements in the field of critical care after his MD, like IDCCM, FICCMO, FICCM. His special area of interest are mechanical ventilation, hemodynamic monitoring, and error prevention. Recently in COVID era, he has one innovation also, error prevention module in critical care medicine, patented and flow drop protocol for optimal utilization of oxygen during COVID oxygen crisis. He is founder of Baroda branch of Indian Society of Critical Care Medicine. He is also a national faculty of ISCCM since 7 years. He has been elected as executive committee member of ISCCM for the term 2020 and 2022 and 2020-22, 2020-24. Now I request Dr. Ritesh Shah to proceed with this topic. Thank you.
Good morning, everyone. Baroda, good morning, and team Gimacon, I must congratulate for this wonderful meeting. I think big round of applause for that. I can give at least 20 seconds for applause because I'm given 10 minutes, so I'll just rush through. My topic is fluid resuscitation, the choice in initial fluid management as well as shock. Why? Because fluid is actually a drug. We have to be very, very cautious, and unfortunately, it is the most commonly misused and overused drug across the globe. Why to kind of understand this? Because if we give less fluid, then less perfusion, it can initiate multi-organ failure. And if we give more fluid, probably our patient presents or goes into edematous state, that is a third space sequestration. And our clinical judgment is only and only 50% of the time right. So we need many subjective as well as objective criteria mixed. And we have IV fluid super duper market, I would say. We only use few of the fluids, but across the world, multiple number of fluids like balanced salt solutions are available that I am not going to go into detail, but maybe in next 5 years we may change and we may forget maybe in next 20 years what is RL or what is NS. So first bit, colloids are more effective in initial fluid resuscitation. Now multiple studies have proven that colloids are most dangerous in initial fluid resuscitation. I am not talking about 500 ml, 1000 ml if we want to give, but I am talking about when if resuscitation is concerned, 2 liters, 3 liters, it can cause dangerous coagulopathy as well as it can initiate renal failure. So crystalloids and crystalloids, no colloids for initial fluid resuscitation I am talking about. Meanwhile, I am not talking again, I will stress upon multiple times, I am not talking about some volume, maybe 200, 300, 500, doesn't matter. I am talking about when we want to load patient with fluid, when patient present with shock, this is not the fluid, only crystalloids. Normal saline is most important saline in our world actually, and it is a big myth. I call it normal saline is not normal, it is abnormal saline. Why? Because see this, our pH of plasma is 7.4 and see pH of normal saline it is 5.7 and with a bit higher osmolality. So it is actually tonicity and osmolality both. So it is actually a hypertonic fluid. So when initial fluid resuscitation is concerned, NS can cause dangerous hyperchloremic metabolic acidosis. So any patient who present with shock, already having metabolic acidosis, we load with fluid and ultimately the acidosis worsens. It's actually the contrary to our purpose, right? So it is very, very dangerous if we want to give higher amount of fluid. NS is actually not the choice. Another myth. Any fluid can be used for resuscitation. I would say see the lactated ringer. It is kind of as close as possible to our plasma. You see this osmolality is around 273 and all chlorides are also closer, so that RL kind of is most physiological as compared to our plasma. So if we want to give fluid as a resuscitation measure, the best fluid for resuscitation is ringal lactate minus. Meanwhile, it is slightly hypotonic. So if patient is having traumatic brain injury, we do not give any hypotonic fluid in traumatic brain injury. Why? Because the brain swells in hypotonic fluid. So minus TBI in all patients, if we want to resuscitate with fluid, ringal lactate is far ahead than normal saline. Myth number 4, 5% dextrose is as good as NS or RL. Actually 5% dextrose, again I will stress upon this. You see this osmolality, 252, significant hypotonic fluid. Any significant hypotonic fluid, see this, if we give 1 liter of 5% dextrose, see what happens. Kind of 1 liter, just at the end of 20 to 30 minutes, only 85 ml remains in intravascular compartment, rest all leaks out. Leaks out means we see as edema. And intravascular volume is less and patient is edematous. Again, contrary to our purpose. So 5% dextrose is not a good fluid for as compared to NS or RL. We don't consider actually 5% dextrose as any kind of fluid resuscitation measure. So it is a calorie. Okay, perioperative status or patient is NBM or patient ke khadu pidu nathi 2-3 દિવસથી, let us give 5% dextrose. It is a big myth. Why? Because See, this 1 pint of 5% dextrose gives only and only 500 kilocalories. 100 kilocalories with 25 grams of dextrose. So if we want to give loads of calories, then we need at least 5 liters of 5% dextrose, which we never give. So if we give 2 liters of 5% dextrose, that is 4 pint, only 15 to 20% of the calorie requirement is been fulfilled. So 5% dextrose as a calorie supplement is also a big myth, and it should not be considered as fluid or as a supplement to calorie. We can keep patient NBM except if patient is diabetic, to prevent starvation ketosis, we can give as a maintenance fluid, but not as a fluid for resuscitation. Another myth, if patient is in shock, the first vasopressor is, what we think is dopamine or dobutamine. Now studies have proven across, I won't go into much detail because of the time, but the first vasopressor of choice, irrespective, I am again stressing upon, irrespective of shock, is only and only noradrenaline. No dopamine, no dobutamine, even in cardiogenic shock. That is the next myth that I am covering. But the thing is that any patient who is hypotensive in shock, if we want to start vasopressor, noradrenaline, noradrenaline and noradrenaline. Okay, so there is no role of renal dose dopamine. It is obsolete since last 15, this is the 15th year, it is obsolete. Yes, if we start dopamine, that is kind of low dose renal dose, so-called dopamine, you will see the fluid coming out. It is like a diuretic. Even if patient is significantly intravascularly volume depleted, if we give Lasix, probably there might be some urine at the cost of intravascular fluid depletion. The same thing renal dose dopamine causes that blood pressure may come up, diuresis may be there, but there will be significant hypoperfusion. So it is very dangerous that there is no role of renal dose dopamine, no role of dobutamine in initial shock, only and only noradrenaline. So is it a good choice for cardiogenic shock? Actually no. Even in cardiogenic shock, the first choice of vasopressor is noradrenaline and only noradrenaline, because dobutamine is a vasodilator. See what happens that multiple times I receive patient with dopamine and with dobutamine both together in different pints. So dopamine causes vasoconstriction, dobutamine causes vasodilatation. So body gets confused what is going on. So it is actually add on to the body stress, the how to handle. The receptors are already saturated. So first and foremost, again in cardiogenic shock, the first drug or vasopressor of choice is noradrenaline. If blood pressure is less than 90 systolic, if you start dobutamine, then definitely you will have it. Patient may go in dangerous shock and further multi-organ failure. So another myth, serum albumin is less than 2.5, let us transfuse. I will say not infuse. It's a human product. Any human product, if we want to give, it is called transfusion of albumin. So we like blood. So we are literally thinking twice before giving PCV or blood. The same way we need to give albumin. That the common belief is, okay, the wound healing is better. If we increase serum albumin, the mortality is better. It is a big myth. There is no role of electively giving albumin except in certain circumstances, because serum albumin is an acute phase reactant. If we measure in all sick patients, in 99, not 99, 100 out of 100 patients, albumin will be low. That doesn't warrant that we transfuse albumin, and albumin is a human product. It can have same kind of adverse drug reactions. Isolite P, isolite M, just for sake of this, I am not a pediatrician, but as far as adults are concerned, see this, it can cause dangerous hyperkalemia. See the potassium content as well as hypertonicity, hyperosmolarity. Both are extremely hypertonic and extremely hyperkalemic fluid. So we have to be very careful, and there are no studies which suggest that isolite P and isolite M are good even for routine maintenance fluid. Another myth, last but I've included one slide of taken liberty because blood is also kind of colloidal fluid, that okay, we need to keep 10 grams of hemoglobin. Big no. If we are having 7 grams of hemoglobin, it suffices, because more than 7 grams, if you just keep on transfusing, it does not increase any kind of oxygen carrying capacity. So 7 grams is good enough, minus that patient is already having bleeding or patient is having chronic anemia with very sick illness. Only 2 indications. So we should not transfuse any kind of PCV if the hemoglobin is 7. So I'll just conclude. So please use fluid as a drug. RL is the best solution. NS is actually abnormal. Think of when we want to give initial fluid resuscitation. No role of colloids. No to 5% dextrose as a fluid as well as for calories. Albumin is not to be transfused just like that. 7 gram hemoglobin is okay, and probably we might have a better fluid in near future in terms of balanced salt solution. Thank you very much. And I'm happy I'm not seeing this. Any question? I'll be happy to take. It is a 2-day CME actually. So,
Sir, you loudly stressed to use RL over NS. But RL contains lots of lactate and as well as potassium. If a patient is in shock, he would not have passed urine also. So what is your take on that?
it's a very good question. Actually, RL definitely contains lactate. But except in fulminant hepatic failure, this lactate is converted into bicarbonate through liver. So even if you give 5 liters of fluid, it does not cause or add or increase lactic acidosis. So mind well, lactate is just kind of as a fuel that it is there, but it does not cause hyperlactatemia or lactic acidosis in that matter. And potassium, see 500 ml is just 4 milliequivalent. It is nothing even if we give 3 liters, 4 liters, 5 liters, even in hyperkalemic patients, does not cause further hyperkalemia. Rather than that, if patient is already hyperkalemic, then we need to kind of tackle hyperkalemia separately rather than restricting fluid like RL.
Thank you.
Fluid management is dengue. So fluid management is dengue. Again, it is like a pancreatitis. It's a bomb. There are 5 inflammatory bombs that we are having, which are not kind of septic in terms of bacteria or bacterial endotoxins. So dengue is a profuse leaky capillary syndrome. So more you give, more will be extravasated. But that should not restrict us for initial fluid resuscitation. These are the patients that you expect edema on day 2, day 3, day 4. Even if, as I said, that patient may be having edema, full-blown edema, but significantly less intravascular volume. So we keep on giving fluid, except edema up to certain extent. In later on, de-resuscitate with diuretics, that is not a problem. And second thing, that there is some role of albumin in dengue. There are some papers, but mind well, they are 5% albumin and not 20% that we are having. So 5% albumin may have a role, but there are no reports which suggest that it is having mortality benefit. So give good amount of fluid. Same, I would insist with RL only and accept edema. Thank you very much.
Thank you. Dear friends, if you sit for more than 4 hours per day, then 125% increased risk of cardiovascular disease such as angina or heart attacks. So, ઘણા બધા ઊભા થઈ ગયા છે. ચલો તાળી પાડો. Thank you, Dr. Ritesh Shah sir, for the superb talk of today. Now I welcome you down the stage for the felicitation, and I request Dr. Dainik Savani to present the memento to sir. I also welcome all the chairpersons, Dr. Ashutosh Singh Rathore and Dr. Dainik Savani, to come down the stage for the felicitation. And I request Dr. Suresh Damor and Dr. Rinki Shah to present the memento to our chairpersons. To chair the next sessions, I invite Dr. Kiran Shah sir and Dr. Mayur Adalaja sir on the stage. Dr. Kiran Shah sir is a senior consultant physician, and Dr. Mayur Adalaja is a Dean GMERS Gotri. He is also professor and head respiratory medicine. Now I welcome Dr. Vijay Thakur sir on the stage for his talk on endovascular techniques in vascular surgery. And I request the chairperson to introduce Dr. Vijay Thakur sir. Thank you.
Hello. Good morning. I think Dr. Vijay Thakur is well known, very renowned vascular surgeon, and he doesn't require any introduction. Sure, Vijay bhai? Okay. Anyway, his major achievement is the Muller-Osten Fellowship, Germany 2000, SV Fellowship, USA in 2000, VVF Fellowship, USA 2012, and he is a member of Founder President's Vascular Society of Gujarat, and so many. I don't think he require any further introduction. So, over to Dr. Vijay Thakur, please.
Thank you, Kiran bhai. Good morning, chairpersons, friends and colleagues. At the outset, I would like to thank IIMA Baroda for organizing a superb conference, Gimacon 2022, and also thank Gimacon team for today's invitation and a podium privilege. One more I want to thank for providing a step for short people like me. You know, first time it rarely happens that, my face is seen above the screen, but first time I'm on the step and I feel so happy. The world is different. I'm here to share, make you aware about endovascular solutions for different vascular diseases. It's a specialty by itself, and I'll take you through a very quick tour of what all we do in our practice. As all of you know, the surgeries are becoming minimally invasive. So is for vascular surgery. We do not have laparoscopic or robotic assisted vascular surgery, very few though, but we have lots of endovascular procedures, and they are because of tremendous development of biotechnology with scientific and commercial interest both. And they're certainly good for the patients because it does reduces morbidity, mortality, complications, and that's why it is safe and very attractive options by the doctors and by the patients too. And these are the advantages to mention. It certainly has very low morbidity, mortality, very short hospital stay. We analyze our length of stay of our patients, it's nearly 1.5 to 2 days maximum. So this is remarkable. It has a quick recovery time, early return to work, all under local anesthesia, hardly any pain, great success. And that is why, because of all these qualities, these days time is money. People don't want to spend time in a hospital. So that's why the outcomes are good. So that's why it is safe, effective, and I would say attractive to both. But having said that, there are certain areas where probably endovascular is the only option. Few of them, like the brachiocephalic area, somewhere around this place, you see innominate artery. If you want to operate there, it needs a major surgical commitment. You need a thoracotomy, aortic clamping. It certainly carries some morbidity. With an endovascular, just a prick, needle prick, and you can solve this. You can fix it. Similarly, intracranial AVMs and embolizations, I think next speaker is going to talk about it. So these are the areas where endovascular is the only treatment option, but no other option. And there's a paradigm shift in patient management. Earlier, part of my practice, I used to spend a lot of time in operating room, which has shifted to cath lab. So from patients also good, from ICU, they're back to room on the same day, and the morbidity is much less. These are the list where we use endovascular procedures for different arterial conditions. Virtually everywhere, from head to toe, wherever there is an artery or vein, you can apply endovascular procedures, intervention, and practices. I'll show you a couple of examples. Similarly, for veins also, there are a lot of indications like DVT, pulmonary embolism. You heard in a previous symposium about role of penumbra in pulmonary embolism, filters, venous angioplasty, which was unheard of some 10 years ago. All of you know about varicose vein endoablations. Social media is full of those posts, and even for certain gonadal vein or ovarian vein embolizations, for pelvic congestion syndromes, which is really unknown or less known to many of us. Now, being a vascular and endovascular surgeon, I jokingly tell my patients that, look, I am the one who will give you unbiased opinion about the modality of treatment. VC is smiling at me because if he goes to a cardiologist or IR guy, he would say IR or cardiology is the best, endo is the best, surgery would say surgery is the best. I say I do both. So I'll tell you which is good for you based on the symptoms you come to us, the kind of lesions you have, your age, medical comorbidities, and cost effectiveness. Of course, in our country, it matters a lot. And if you want to practice this, These are a lot of tools you need to practice. I'll take you through a couple of cases we do. Our major practice is interventions for leg ischemia, leg angioplasties. And way back in 1964, Charles Doctor did his first ever angioplasty, and then after, there is no look back. The industry, the science, technology has improved so much. Unbelievable. And luckily good for our patients because most of our vascular path patients are elderly populations, the diabetic, hypertensive, smokers, many of them have renal dysfunction. They're very high risk to operate under and to go through post-operative stormy outcome. They come to us in a late stage, multiple level disease, extensive disease. In such cases, we do surgery, but it certainly carries some kind of morbidity. And when you want to treat any leg ischemia, these are the options you have: best medical management, angioplasty, bypass, or I call vascular homeopathy or indirect revascularization, where we have no revac option available. Probably we do stem cells, HBOT, prostaglandins. Honestly, I don't know. I do it practice, but I don't know how much it works. I'll just show you one case, few cases rather. An elderly gentleman, 78-year-old, presented with a very severely ischemic leg, rest pain and gangrene. All possible risk factors. You can see on an angiogram, he has multi-level disease. His left iliac is occluded, his left femur is occluded, he has symptoms on the left leg, the right is occluded. So these kind of patients, if you can offer them, so these patients has options like aortofem bypass, femper bypass, or angioplasty or hybrid. Now looking at the risk factors, of all of us, all these days, most of the doctors would prefer this. It's a very safe, effective, and a durable option. It is not only safe, you have to also think in terms of durability, that you are spending money now, how long it is going to last. So iliac and aortic interventions are nearly at par with surgery as far as durability is concerned. And the morbidity, there is hardly morbidity to mention, and I would say zero mortality unless something goes wrong. And when the same patient undergoes surgery, he'll have list of complications to somewhere or other he might get into this. So to avoid this, we'll always try to do endovascular procedures. Another example, index case, look at the high-risk patient, very obese guy, 76-year, presented middle of night with acute paraparesis, ITP for 30 years, very low platelet counts. He cannot undergo laparotomy and aortic fixing. I think he has no option but to undergo angioplasty like this. Another guy, fit man relatively, but a short lesion. Again, you can't open barely for his short lesion, angioplasty. So what I want to convey, high-risk patients, right kind of lesion to treat, angioplasty is the way to go. Even now, having in practice for almost 2.5 decades and more, we get our patients back. I always tell all the patients that no cardiovascular disease is curative, right? We see, except PDA closures. Everything is palliative. They are going to come back to you. Maybe bypass or an angioplasty. We get our patients back, and especially aortic angioplasties. Redo is a nightmare, and angioplasty does offer a pretty good option. So we move on to the little lower down from aortoiliac to mid-thigh into femoral artery lesions. Luckily, most of the patients only with occlusion also might have just claudication. If it is not lifestyle limiting, probably we treat them with medical therapy, best medical management. Or else, if they have a shorter lesions, we prefer to do angioplasty like this. Otherwise, bypass surgery certainly offers a better and a longer durability. At the same time, there is not much morbidity or mortality. At times, we have new technology, new stents like Supera or vascular mimetic, where those guys who do angioplasty, they know calcium and thrombus are the enemies of angioplasty. So if you have very calcified lesions, your balloon won't open it up, stent won't open up. You need something like atherectomy devices or special stents like this called Supera stents. Same with tibial. In fact, patients having tibial disease are more sick, they're worst. They're elderly population. They have poor cardiac and renal functions, compromised leg circulations, often bilateral circulation. And these patients, such a long scars, I think they stay in hospital for a long time. If we can offer angioplasty, is nothing like this. Like these patients, you see multi-level disease, proximal anteriotibial, mid-anteriotibial, distal anteriotibial. You can fix entire thing with an angioplasty in an hour or so. So it does help them for wound healing, for relief of rest pain. These kind of angioplasties may not remain open for ages, but objective is different here though. Similarly, another guy, multi-level disease, all you can fix. Look at the profile of patients we are seeing on the screen. They're elderly population, diabetic, severely other comorbidities. I don't think they are fit to undergo any surgery. Though our anesthetists are brave enough to, they accept all our patients. They hardly say no. What about upper limb angioplasties? We do not see a lot of upper limb cases. Our main practice is lower limb angioplasties. Upper limb practice is mainly, they are not because of occlusions. You might see many patients who have occluded subclavian artery and they are asymptomatic and they don't need any treatment per se. Only thing when they have some symptoms like thromboembolic, you got to fix them with angioplasty. The previous case I showed, brachiocephalic, no option but surgery only. This is something, people, I remember early part of my practice, I was scared to handle such patients of aortic aneurysms or thoracic aneurysms. We do it pretty routinely now, I think maybe 7 or 8 in a year, not a big number though, but we keep seeing, they all are our pictures. We keep seeing these patients. And these patients are sick patients. If you don't treat them in time, they will die. They rupture and they die. Whereas when you treat them, we have beautiful options called endovascular treatment options, EVAR for abdominal aneurysms and TVAR for thoracic, and lot of advantages. I wouldn't think twice. If patient is elderly, I would offer them EVAR or TVAR. Recently we did this case, very recently, very complex case, aortic aneurysm, huge one, juxtarenal, wherein we did 2 chimneys into renal and the stent. Look at this. This is something like, life-saving and very, very satisfying to patients and to us both. Only issue today is they're pretty expensive. Another segment of disease we treat is kind of DVT. Many of us treat DVT. Not that all these patients require some kind of interventions. There are physicians sitting in the audience. They must be thinking, well, if you are happy, with LMWH or NOAC, why offer them an intervention? Unfortunately, we do not know who are those patients who have pretty good endogenous fibrinolytic activity. There is no test so far available. There are indirect tests. No test telling you that this patient has a very good fibrinolytic activity. If you know that, probably you can decide that this guy will be okay with medical therapy, other guy goes for the intervention. So these are the list of things we treat them. I put it this way, that the advantage of thrombolysis is to prevent post-thrombotic leg syndrome. Those surgeons who are seeing those LDS and venous ulcers and scleroderma, I think these patients, I tell them they have no cure. They are miserable, the quality of life is really very poor. So to prevent that little late complication called PTS, post-thrombotic leg syndrome, I think we should offer them some thrombolytic therapy if possible. In the index case, a lady had a DVT after fracture, was rightly treated with LMWH and NOAC for 2 weeks without any relief, so she was referred for intervention. And a Doppler is a very simple test to diagnose DVT. They can hardly miss it. Rarely ever we do CT venography. This is a CT venography, just for your information. I brought this picture. Again, this guy was a doctor by himself, and the entire iliac vein was occluded. For his satisfaction, we got CTV, otherwise don't get CTV. And this is a tool we have called thrombectomy device. For last 7-8 years, we have been having this. We are the first in the country to procure this, and fantastic results. Thrombus anywhere in the artery or vein, this device can break it. It can pulverize it. It emits saline at the speed of 300 kilometers per hour. It breaks the clot and it sucks the clot. So wherever clots are, all the clots will be aspirated. And you get a very clear vessel bed. This patient, the previous one I showed, treated with LMWH in the right dose, NOAC in the right dose, and despite that there was no relief. The same patient underwent angioid thrombectomy. You see the entire continuity, the revascularization is pretty superb. This is not possible to achieve with any tons of heparins or LMWH. Those guys who do not have the access to this machine, they also have an option of putting just catheter there for a right time with the right drug, and you might achieve a very good result, though this patient required kind of a stent, but it does work. A word about, I have to rush because I have to cover so many things. It's just kind of a trailer of 20 minutes of a movie of 6 hours. So IVC filters, a word, many friends of mine are fond of putting filters, but be cautious about filters. Filters do carry a problem. Filters only have a right indications. If you cannot anticoagulate them, if it fails, then only use filter. Even if you have to use a retrievable filter, otherwise you'll see complications like filter migrations, IVC perforations, and thrombosis. Another commonest practice in our group is some interventions for varicose veins. We do a lot of interventions. And as I said, you need to know what kind of vein you are treating. Not that all the veins, what you see, need some kind of treatment. Unfortunately, I've been seeing this in practice these days. Any vein is, subjected for investigations and the treatment. Not that they need treatment. You need to identify it's a saphenous, reticular, or kind of a pelvic vein, because the treatment modules are different for all these veins. Again, color Doppler is one test which will offer you all the investigations you need. And we have all the different gadgets to treat varicose veins. I've been treating varicose veins with laser from ever since 2003. So many years we have been using lasers. We also have radio frequency ablation. There's a new kid on the block called glue. You must be, I've been seeing in a lot of social media advertisement, glue being misused by many doctors because it is very simple to do, very simple to perform. And MOCA, we've been doing all the technologies. In nutshell, you need to block the refluxing vein with whatever means you can do it, and there are plenty of advantages. Genuinely daycare procedures, those patients who don't need medical insurance, they go home the same day after a few hours, purely under local anesthesia, no scars, early ambulation, no hospitalizations, and hardly complications to mention. I think this is the way to go. Another segment we treat again in a large number is AV axis. Some time ago, me and Sumit presented data in our national meeting. We're the highest in the country to do these fistula angioplasties, imagine. Because this kidney failure is rampant. Those nephrologists would say they're busy. So we make fistulas for kidney failure, for dialysis, hemodialysis. And all these fistulas, whatever you do, fistula, basally, grafts, they tend to block. As I said, any cardiovascular procedure intervention is short-living or living. They have kind of a expiry date. So they come back with occlusion. And when they come back with occlusion, there are instances we have to do angioplasty for them. And when we do angioplasties, we have again a lot of things to do, plain balloons, drug balloons, cutting balloons, cryo balloons. So many things are there, all technological gizmos are there. We try to open them up. Unfortunately, these are the set of patients. We open them up, but all of them come back after some time. So we have to tell them, I always tell my patients that re-intervention is the rule. Another patients, I think I'm going to come to 3 minutes to go. AVM embolizations. I remember something like nobody wants to treat them because the results, the outcomes are not guaranteed. Recurrence is almost a rule. We treat segment of lots of AVMs right from head to toe. And all AVMs have a very kind of a tailored recipe, not that one solution for all the AVMs. We need to identify them. It's venous, arterial, mix, lymphovenous. And based on that, we offer different kind of therapy. I take lectures on AVM for almost half a day, so difficult to summarize in a minute. Just a case to show you. This lady had a large bleeding AVM on the tongue, and she used to bleed off and on, unable to eat. So we did an angiogram, you can see on the picture, there are a lot of feeder vessels are there. We embolized the entire feeder artery, and then we excised it. So this is possible when you have some tools to block those feeding vessels. Many times I jokingly tell that we are bloody plumbers, easily available than plumbers. And we do, why say, because we use catheter skills to block anywhere. This is an example, wherever the artery bleeds, if you can reach, probably we block them. This is with a coil, an example of GDA bleeding in a blunt trauma. Another case of bleeding splenic artery aneurysm in a pancreatitis. Seeing is believing. Now I want to show you these pictures, so back of the mind you'll remember that we are here to do all this. This is a case of post-PCNL bleed. You see a renal artery aneurysm here, which was again embolized with the coil. Thank you very much for your time and attention, and I'll be happy to answer your queries.
Thank you, sir. Any question?
I expected VC to ask something. Go ahead.
That is only because you reminded me we were the first one to do the carotidplasty in Gujarat,
True.
two of us. So at that time, cardiologists and surgeons together work, but now we are apart.
Today also,
Yes.
today also we are ready to work together.
So my question is, if patient comes with carotid tight lesion, in which, and money is not an issue, in which patient you will advise angioplasty versus where endarterectomy? Which is your preference in, other than money?
Yes, based on science. I tell you, as you know, I do both endarterectomy and angioplasty. So I have very, very clear indications. very high bifurcation where I cannot reach surgically, opposite total occlusion, or a hostile neck. These are the conditions where I am scared to enter the neck. Probably I would offer them angioplasty, otherwise surgery, of course, is a better and durable option.
And probably post-radiation also.
Hostile neck, this post-radiation.
In your one of the slides, you shown that the left upper limb ischemia is more than right. Why? Any?
Again,
just anatomical?
No, yeah, I have no answer to this question. It's an observation we have seen.
Okay. So one more fact, continuous sitting leads to zero leg muscle activity. So please stand up once again and clap for his excellent talk. Clap loudly. Now I welcome you down the stage for felicitation. I request Dr. Kiran Shah sir to felicitate sir with memento. Now I welcome Dr. Himanshu Pathak sir on the stage for his talk on approach to joint pain in clinical practice, and I request the chairperson to introduce Himanshu Pathak sir. Please.
Dr. Himanshu Pathak is a consultant rheumatologist. His professional membership are Royal College of Physicians, London, Indian Rheumatologic Association, British Society of Rheumatology, and his area of interest is spondyloarthritis and spectrum of disease. And he has more than 20 national international publications in journals and more than 100 citations. So now all we welcome him, Dr. Himanshu Pathak. Over to you, sir.
Thank you, sir, for introduction, and good morning, everyone. So I've been here since morning, and what I've been listening is all interventions and all procedures, all luxurious stuff. So now coming to the clinics, that's what we do day to day. So I think my talk would be pure clinical talk, as I'm a rheumatologist, so I don't do much procedures. So bear with me. But I think the talk will the takeaway from the talk will help you in your clinic every day. So my outline of the talk is how to identify inflammatory joint pain, differential diagnosis of joint pain, pattern recognition, and what are the basic initial investigations, and how to spot diagnosis of rheumatological condition in a busy clinic. So when we think of joint pain, so this is a study, this is a community-based study ICMR did like 10 years back. And if you see so joint pain are very common. So these are the lay people who researcher asked what are the most common symptoms they have. And you see that the joint pain are the most common symptoms in a day-to-day life of a normal person. So joint pain is very common in all age and groups, but the whole thing is that the interpretation of presenting symptom is as per the context of patient. So we can't take a joint pain in a young patient and a joint pain in an elderly patient at the same level. So the context is very important. So what are the key features to look for in the history? So the key features are duration. Is it acute, less than 2 weeks, subacute 2 to 6 weeks, chronic? Onset, is it abrupt onset? Associated constitutional symptoms like fatigue, fevers, weight loss, associated systemic involvement like association of diabetes, hypertension. So all these things come into the picture when we are taking a history of a joint pain patient. And the characteristic, is it inflammatory or non-inflammatory? Because inflammatory joint pain comes with morning stiffness, swelling, redness, fatigue. Articular or periarticular? Is it joint or periarticular? Is it small joint or large joint? And is it axial or peripheral? Because all this will help you in making a diagnosis during your clinical interview. So the pattern of joint pain. So this is the most important thing which we need to understand, that when we are investigating a patient of a joint pain, is it inflammatory or not? So inflammatory joint pain is more worse in morning. It is more associated with morning stiffness, usually for more than 30 minutes. Sometimes it is at the night. And there are sometimes associated constitutional symptoms. And so this is a diagram taken from Harrison. So when someone comes to you joint pain, so just by listening to the patient and taking a history, so someone who has got symptoms at wrist, so what are the possibilities? Rheumatoid arthritis is most common. Someone who is complaining pain at CMC joint, it is osteoarthritis. MCP joint is usually rheumatoid. PIP and DIP is osteoarthritis. And remember, psoriatic arthritis can involve any of the joints. So the differential diagnosis for one joint are usually trauma, osteoarthritis, septic, crystal, Charcot arthropathy. 2 to 4 joint, same, infection, osteoarthritis, reactive arthritis, rheumatic fever, spondyloarthropathy. So as the number grows, the differential increases, and more than 5 joint usually in our setup is fever, viral fever, chikungunya type, or then connective tissue disease. And then synovitis. So joint pain by itself is not a diagnosis, but if joint pain is associated with joint swelling, which we describe as synovitis, is significant. So with that, what are the routines? So once you have investigated the patient, you have taken a history, and you have come to the diagnosis after your history that this is probably inflammatory joint pain. So what are the initial investigation you should be thinking of? So all patients should get CBC, ESR, CRP, liver functions, creatinine, uric acid. So this is a very common, so we are talking of myths and facts. So the common myth is that someone who's got hyperuricemia, the joint pain is because of that. I only order uric acid in males and in post-menopausal female, because uric acid by itself doesn't cause any arthritis. So that we need to remember. Urine analysis, X-rays rarely, and sometimes ultrasound and CT MRI. And immunology, I would say, don't order the immunology unless you are very sure that the thing which you are dealing is inflammatory joint pain. Because if you do, because these are only immunological tests, they can be false positive. And someone who has got rheumatoid factor positive, low positive, and complaining of joint pain, he may also have osteoarthritis, and it can be mistakenly labeled as rheumatoid arthritis. So we have to be really careful. And then what we need to understand that it is not very imperative, because we are not, we live in real life, and in real life we don't get book picture cases. So sometimes it just starts as undifferentiated. We don't know that what it is. Will it be turning out to be rheumatoid arthritis, or gout, or psoriatic arthritis, or CTD? So just keep all your options open. So just clearly mention that this patient has got inflammatory joint pain with joint swelling, not a clear characteristic of any of the rheumatological disease, and you will keep on monitoring that. Now I will be coming to the pictures of it. So this is the section where just by spotting in your clinic a patient who comes to you with joint pain, and just by looking at it you can probably make a diagnosis. So this is osteoarthritic hand. So remember, so usually the patient profile is someone who is in his 50s and 60s who comes to you with polyarticular joint pain, and you see his hands. So what are the things which you are seeing in the hand? So you see the bony swellings, PIP and DIP bony swelling. When you see a PIP, posterior interphalangeal joint and distal interphalangeal joint swelling, bony swelling, it is osteoarthritis. So, and this is the most common arthritis we have in a community, so not to be missed. Similarly, if you see this type of knee, a valgus deformity, by and large it is osteoarthritis. So these are the things which are not to be missed at the first clinical encounter. You can straight away make a diagnosis here. Rheumatoid arthritis. After osteoarthritis, we see a lot of rheumatoid arthritis. So what is the characteristic? So remember, in rheumatoid arthritis, the involvement is MCP joint. You see the MCP joint swelling. So a patient in his 20s, 30s, 40s coming to you with joint pain and who's got MCP joint swelling, invariably it is rheumatoid arthritis. Usually symptoms are more than 6 weeks. There is a palpable swelling, morning stiffness. It is a symmetrical arthritis. So if all these features are there, you can safely assume that the patient probably has rheumatoid arthritis when you are seeing them in your clinic. And never forget the feet, because we sort of in a busy clinic, we may sometimes never ask a patient to take out shoes. And sometimes the patient, the money is in the shoes, so you ask them to take out their shoes, and you see this deformity, and straight away you can make a diagnosis of inflammatory arthritis. Another one, a young male with back pain and stiffness more than 6 weeks. And you order a back X-ray and you see this type of picture. So this is bilateral sacroiliitis. This is actually ankylosing spondylitis. So any back pain in young patient below 45 or 40 years, especially male, ankylosing spondylitis is one of the very strong differentials. So never miss out of that. So if you see the profile of axial SPA, it is more in male, younger age of onset, at the adolescent, 10, 20s, 30s, 40s. Back pain, especially in morning, nighttime back pain associated with morning stiffness. Sometimes they get joint pain, especially ankle and knee swelling. They may have HLA-B27 positive. So all these are the clinical features of ankylosing spondylitis. Psoriatic arthritis. So psoriatic arthritis is arthritis which can involve any joint of the body. So if someone comes to you with bad nails and joint pain, so you see their nail and we have this tendency that this is a fungal infection. But if the associated joint is swollen, it may be psoriatic arthritis. You can see that. And psoriatic, usually there can be swelling of finger, there can be swelling of joint associated with nails. So not to be missed. And this is, so if you ask them, this could be only one manifestation. So swollen toe, that could be only one manifestation. So this is a 79-year-old male with polyarthralgia, history of psoriasis, and you see that swelling of toes, that is dactylitis. Similarly, patient complaining of back pain, polyarthralgia, and you ask them to take out their shoes and you see the Achilles tendonitis. So this all could be spondyloarthritis or psoriatic arthritis. But this could be just there in your first encounter. Now we are seeing a lot of reactive arthritis nowadays, and we have seen this type of pictures, especially post-COVID also, and we see this after post-chikungunya infection also. So they get this horrible nail reaction and associated with joint pain, and this usually comes under reactive arthritis. They sometimes get oral ulceration, and then there is this very classical sign of keratoderma blenorhegicum, which may look like eczema or something, but if it is associated with joint pain, it is a part of a psoriatic reactive arthritis. And erythema nodosum, not to be missed, painful tender swelling in the legs associated with joint pain could be a marker of spondyloarthritis. And gout. Now the most common arthritis is gout, but just remember that not all hyperuricemia is gout. Number one, and if there is no involvement of great toe or foot, gout is not likely. So don't make this mistake of labeling someone as gout and starting hyperuric uricosuric therapy just on the basis of uric acid levels. So these are the gouty tophi. Sometimes they can be misdiagnosed as osteoarthritic. And just that sometimes their tophi could be there also on the hands or the fingers. So after that, coming to connective tissue disease, systemic lupus, young lady with butterfly rash, photosensitivity. If she has some constitutive symptoms, joint pain, always think of lupus. And then they have this erythematous rash, which usually spares the joint MCP, PIP, DIP joint. And in the later stages, you can see the you can see that there is this demarcation of the skin in between the joint. So this is also lupus, erythematous circular rash, digital tip ulceration, gangrene, all could be there, vasculitis, they all could be present with joint pain. And this is another presentation of lupus, acute lupus. Patient has been to dermatologist, constitution symptoms, ultimately diagnosed as SLE. Central clearing rash in a young female is usually, most of the time, it is lupus, and this is a discoid lupus. And this is one of the patients who has got joint pain. He's been on a therapy for say 4 or 5 years, which he's been taking twice or thrice a day, and he thought that this therapy is because of the joint pain. Does anyone know what is this? What medication he might be taking for joint pain, and he has ended up with this hand? Any guesses? So he actually was on hydroxychloroquine, which he was taking like 3 or 4 times a day. And this has got hyperpigmentation because of the hydroxychloroquine therapy. And then I stopped his hydroxychloroquine, and we can appreciate that his hyperpigmentation was clearing up. So coming to the another part, dermatomyositis, facial rash, heliotrope. Then here the differentiation here is that with lupus is that here the rash is on the joint, the PIP joints and DIP joint. And then sometimes they've got swollen whole finger, could also be there. And then periangle changes. So just looking at the finger, surrounding area of the finger, someone who's got joint pain, erythema around the finger, you can make a diagnosis of something connective tissue going out there. Then this shawl sign, they have this photosensitive rash, dermatomyositis patient, which is only on the sun-exposed area. And here you have to actually lift it up. The patient will not tell that they have got this, so you have to examine in this way. And this is one of the feature which is a recently diagnosed condition, which is anti-synthetase syndrome. So this is one of the category of dermatomyositis, where the patient has got arthritis and interstitial lung disease, and they have this very specific roughening of the finger, which is known as mechanic's hand. So if you see that patient who's dyspneic, joint pain, and this finger, you can straight away make a diagnosis of anti-synthetase syndrome. So all these things without any investigation you can do. And now this ulcerative erythematous rash, we are seeing this a lot after COVID also, but this is also a marker of a connective tissue disease, vasculitis. And then very common, especially in pediatric age group, palpable purpura, IgA vasculitis or Hanasch-Losschen purpura associated with joint pain. Saddle nose deformity could be a marker of Wegener's, could be a marker of syphilis, leprosy, so not to be relapsing polychondritis. And this, that, sometimes we get this also, patient is unwell and you see this and you examine, there is nothing, patient only has got joint pain, but there is only the splinters. And the patient is in ICU, unwell, febrile, tachycardic. So this is infective endocarditis related splinters. And this is is the scalded skin syndrome or toxic necrolysis because of infection. So not everything is autoimmune. We have to keep our clinical mind thinking that there could be other things. So if you see joint pain with any pustule, always think of infection, probably gonococcal. And never to be missed, any joint pain, associated erythema on the joint, septic arthritis. Always stick a needle in, take out the fluid. And hypertrophic osteodystrophy. This patient can also have joint pain, especially at the end of their long bones, and nail clubbing. And this could be only clue for underlying malignancy. So not to be missed. And just for the sake of time, I have not covered the pediatric and adolescent age group, but so this is the long differential in pediatric age group of the joint pain, not to be missed. And why do we want to identify or categorize or diagnose a patient of joint pain? Because if a patient of inflammatory arthritis remains undiagnosed, this can happen over the time period. So you see that whole destruction of the joint. So this is actually radiographical destruction, which is irreversible. So this is time lost, this is bone lost. And if you misdiagnose inflammatory arthritis, rheumatoid arthritis, the patient will end up like this. So in this day and age where we have all the therapies, all the investigation, not very expensive, letting our patient going from this stage to this stage is, I think, is criminal. So we have to make the diagnosis early. Similarly, it's a very famous diagram of an American trooper from the Second World War. So he had ankylosing spondylitis, but because there was no adequate treatment, this is what happened to him in the next 30-40 years. And that's what we want to prevent by identifying and making an early diagnosis. Thank you.
Any questions?
In psoriasis, if arthritis precedes over skin lesion, how you diagnose it?
Yeah, so about, there is always a possibility about 10% of psoriatic arthritis patient in psoriatic arthritis actually precedes psoriasis. So how can we, so usually this patient has seronegative. So all patients who are rheumatoid factor, anti-CCP or ANN negative, but they've got joint pain and swelling, and you can say that this patient has got inflammatory arthritis, keep an diagnosis of undifferentiated arthritis. So that's what the thing which I said, that keep on monitoring them. So you have to treat them. So the treatment is not different. Treatment is same as rheumatoid or same as psoriatic, but you have to label them as an undifferentiated arthritis and say in next 3 or 4 years they may develop psoriasis. So keeping the diagnosis open is also important.
Horror movie. It was very scary because I thought these diseases are over and seen only in textbook. Now my question is, best thing is I learned that we should refer patient to the right appropriate person rather than treating ourselves. But can 2 or 3 different type of arthritis coexist, or 2 or 3 different diseases coexist, because the treatment would be very different in that type of situation, as you mentioned very rightly.
Yeah. So yes, the coexistence of inflammatory arthritis is not uncommon. So the most common coexistence which we see is rheumatoid arthritis and osteoarthritis. So the patient has got inflammatory joint pain, and patient also has got mechanical joint pain. So the key thing is, so there comes our clinical expertise where to differentiate at the moment what are the symptoms which are predominating. Is it osteoarthritis? Because as sir rightly said, that the treatment of osteoarthritis is completely different. So you don't want to use disease modifying or steroids for osteoarthritis. So, and similarly we see a lot of combination of inflammatory arthritis, osteoarthritis and gout also. And unfortunately what happens is that the patient of rheumatoid or osteoarthritis, everyone gets uric acid is 7, and everyone is on hypouric therapy. Everyone has allopurinol and fabric acid. So this we should not be doing that. So we have to be very clear that what is it, only joint pain or is it arthritis? Because joint pain and arthritis is completely different. As I said, I didn't dwell on the condition named fibromyalgia, which is also very common so it is just a chronic pain. It is a centralized pain also. So this all could coexist, and as in rheumatology most of the conditions are chronic, they develop this central sensitization and chronic pain. So sometimes we end up just treating pain instead of arthritis.
Last question. Apart from the pharmacological management, in particularly large joints, particularly knee and ankle and somewhere, is there any role of traction for the prevention of further progression of the disease?
Sir, are you asking about traction? Yeah, no. I mean, we don't. In rheumatology, we don't advise any tractions because I think we have gone past that stage.
To relieve the pain or to relieve the pain or?
No, as I think, sir, we have gone past that stage of tractions now because we have got so much effective pharmacological therapy available that we don't advise traction.
Thank you. One important announcement is there. Those who want to enjoy live snake show can proceed outside this hall. Our committee members have worked really hard to gather many different varieties of snakes since last many days. So you can enjoy that live snake show outside this hall. Now, dear friends, we all know that standing in between different scientific sessions leads to decrease in your back pain and boost up your mood and focus. So please stand up and clap loudly. Thank you, Dr. Himanshu Pathak sir, for the excellent talk. Now I welcome you down the stage for the felicitation, and for the same I request Dr. Mayur Adalaja to present the memento to Dr. Himanshu Pathak. I also welcome Dr. Kiran Shah to come down the stage for the felicitation, and for the felicitation of chairpersons I request Dr. Bhikhubai Patel and Dr. Nutan Shah madam to present the memento to our chairpersons. Since we are running a bit late, so we will skip the tea break and continue with the scientific sessions. However, tea and coffee is being served in the refreshment area.
But jo baka, cha pીવાની, coffee પીવાની, રેવડી નહીં ખાવાની. બરાબર ને?
To chair the next sessions, I invite Dr. Bhikhubai Patel sir, Dr. Tapan Shukla sir, and Dr. Piyush Waghela sir on the stage. Dr. Bhikhubai Patel sir is a senior consultant surgeon of Baroda. Dr. Tapan Shukla, a senior practicing ophthalmologist, and Dr. Piyush Waghela, a senior consultant pathologist working at GMERS Gotri. Now I welcome Dr. Bhagwati Salgotra sir on the stage for his talk on endovascular intervention in neurovascular cases, and I request the chairperson to introduce Dr. Bhagwati Salgotra sir.
Good morning, everyone. On behalf of IMA team and all the members sitting here, we welcome our chief speaker today, Dr. Bhagwati Salgotra. His specialized skills is on epilepsy surgery, endovascular, neurointervention, MIS spine surgery, MIS TLIF surgery, aneurysm clipping, CV junction surgeries, endoscopic MVD, and transforaminal endoscopic dissectomy. He is a member of Neurological Society of India. So we welcome you, sir, and we request you to share your insights on the subject. Thank you.
Thank you, sir. Thank you for welcoming me and for this introduction. I am Dr. Bhagwati Salgotra, and I am neurosurgeon and intervention. I do neurointervention. I want to give a brief idea of the neurointervention cases we are doing at Zydus Hospital. Before I start, I tell you, we have a big team of neurosciences at Zydus Hospital. We have 2 neurologists, and I'm a neurosurgeon there. And there is no biasing towards the intervention, because a lot of people will think that being interventionists, they'll have a bias towards intervention. But we have a team, and we have a multidisciplinary approach towards the patients. These are the various cases we come across regularly, like aneurysm, ruptured aneurysm, we do coiling, AVM, we do embolization, carotid-cavernous fistula, mostly traumatic we do embolization. Stroke is one of the very common indication. When we get a large vessel stroke, we go for mechanical thrombectomy, which is a gold standard now, and we do carotid artery stenting. Just a brief introduction of stroke before going for intervention. We have, mostly we see ischemic and hemorrhagic stroke. We have CT-based as well as MRI-based protocols to evaluate those patients. Usually in stroke, we have a core ischemia, and there is a salvageable penumbra. So first thing we have to rule out is bleed, and then when we conclude that it is a ischemic stroke, we go for checking out the penumbra. There are the guidelines. If the NIHS score is more than 6, aspect score is more than 6, we definitely go to salvage the penumbra. Mechanical thrombectomy over the period of time has been evaluated by various trials and now has emerged as a gold standard for dealing with large vessel occlusion. I just shared this case. This is a 67-year-old male, and he presented within 4 hours of onset of stroke. He was a known case of ischemic heart disease and hypertension. When he presented, he had right side, left side complete hemiplegia, right side forced deviation. NIHS score was 18. On CT angio, there was M1 occlusion, and there was a diffusion flare mismatch. Usually when there is a clinico-radiological mismatch, or when there is a diffusion and flare mismatch, and if we know that on the flare there is a lot of brain which can be salvaged, we go ahead. This is the image of the CT angio. We can see there is a large vessel occlusion. The right M1 is occluded here. We took the patient in cath lab, and this was the right side M1 occlusion. This was after the thrombectomy, nice TK3 flow we have achieved. This was the thrombus which was retrieved. This was the pre-procedure angio, and on this side we have the post-procedure angio. So nicely the vessel was recanalized. Post-operative CT showed mild edema in the basal ganglia area. This is the core infarct, so this cannot be salvaged because, as we say, brain is time. So with each passing minute, million of neurons are dead. So our aim of intervention is to save the penumbra, and a lot of time we get a residual core. Another case, a 75-year-old female, she presented within again 4 hours of onset of stroke. She was a known case of hypertension and ischemic heart disease. On MRI, there was this large left hemispheric stroke, and on MR angio, the complete ICA was blocked. We went ahead with the mechanical thrombectomy. See on the angio, the terminal ICA is blocked, but there is no flow on the left hemisphere completely. But after mechanical thrombectomy, there is a nice TK3 flow over the left side hemisphere of the brain. This was a long clot which we retrieved using a stent retriever. This is the pre-procedure angio. And on other side, this is the post-procedure angio with nice flow. Whenever we are dealing with a very large penumbra, there is always risk of reperfusion injury or hemorrhagic conversion. So in this case, there was hemorrhagic conversion of the cortex. Fortunately, the post-operative edema was not that much, and patient did not go for mechanical thrombectomy, decompressive craniotomy. This another case I would like to share. It's a very interesting case. We'll first see the video. See, the patient is showing. Just keep an eye on his left hand. There is paroxysmal jerky movement of left hand. It's not a sustained jerky movement like a convulsion. So this patient had limb shaking TIAs. The transient ischemic attack can also present in such a form of limb shaking TIA. It's a very rare presentation of transient ischemic attack. Usually it occurs when the contralateral hemisphere is hypoperfused. The flow in that hemisphere is very low. So this patient has presented. He was 64-year-old male, non-diabetic, and presented with limb shaking TIA. On workup, we found that there were these watershed area small strokes, multiple small lacunar strokes in the right hemisphere watershed area. Again, this signifies that the right hemisphere was hypoperfused. On angio, there was right carotid 90% blockage. So this was the 90% blockage of beginning of the internal carotid artery, which was relieved by stenting. This is the pre-procedure angio. You can see a atherosclerotic, mildly calcified plaque, and this is the post-stenting video showing nice recanalization, and he was relieved of these limb-shaking TIA. Now, we'll just see another video. See, note the hand movement along with the face movement. This is not a limb shaking TIA. She is undergoing a focal convulsion. But see, the convulsions are not stopping. If we are allowed to go on watching this video, she was in this movement for next 15 minutes. So focal convulsion for more than 10 minutes. So this was epilepsia partialis continua. So this is also a very rare presentation of stroke. Patients of stroke will not present with focal convulsion. If we see the overall patients of stroke, only 3 to 4% patients, they present with focal convulsion. And very rarely we will see epilepsia partialis continua. So on workup, we found that this patient had a stroke on the right motor cortex. On angio, there was 60 to 70% blockage on the internal carotid artery, which was giving these embolic showers. This is the pre-procedure angio. There was moderately calcified plaque, and this is post-procedure. The vessel was nicely opened, nice vascularization. Now, another segment which we very frequently come across is the cerebral aneurysm. Patients with ruptured cerebral aneurysm present like stroke, but when we work up, we come to know that there is a diffuse subarachnoid bleed. There are two ways of handling these patients. Either we can go for open surgery and clipping, or we can go for the minimal invasive intervention, the coiling. Usually we get most commonly the ACOM aneurysm. Another most common site is the MCA bifurcation. Less common are PCOM and basilar top. I'll share this case. It was a very interesting case because there was this 73-year-old female. She presented with acute onset spontaneous subarachnoid bleed. On CT angio, there was a ACOM aneurysm, but the vessel showed such anatomy that the A2 were originating from the neck of the aneurysm. So it was little difficult to coil, difficult for a flow diverter, and it was good case for open surgery. But the relatives were very adamant. They wanted to go for only endovascular coiling. So we had to use a 2 microcatheter technique. This technique we use when we have to salvage certain part of the aneurysm. So we can, this is the post-op CT scan which is showing a nice coils inside the brain. The SH has resolved. This is the angiographic images. So 2 microcatheters were used, and then coiling was done. In this technique, a large 3D coil ball is first created, and in that 3D coil, another 3D coil is used to pack the dome. So the package is more towards the dome rather than towards the neck. So any vessels which are originating from the neck can be saved. Post-operatively, patient was kept on aspirin. So this 2 microcatheter technique is very less used. This was the pre-procedure angio. We can see the vessels originating, the A2 originating from the neck of the aneurysm. This is the post-angiographic image. Little sluggish flow on the contralateral A2, but there was a good flow from the other side. So there was nothing to worry. Still, prophylactically, we had kept the patient on ecosprin. Another segment is the paraclinoidal aneurysm. These are little difficult to deal surgically because we have to drill the clinoid process. So drilling the clinoid process is little difficult. Not impossible, and it is very regularly done in many cases, but many times endovascular is much easy and readily available modality for such cases. I've just shown a schematic diagram here. There is an anterior clinoid process, and the aneurysm is hiding behind the clinoid process. After drilling, we can clip it, but let's see some endovascular cases. This was a paraclinoidal aneurysm with a narrow neck. See, it looks like a hanging some grape. So the neck is narrow and the dome is quite big, like a pot. So you can fill up the coils. So this is the post-coiling image, nicely coiled. This is a schematic diagram to understand the coiling in these cases. Another case where the neck was wide. So these cases, the coil cannot be held inside the dome. So we need to put some stent to control that, and the end all the coils can compactly stay inside the aneurysm. So this is on the left side we have a schematic diagram to understand these cases. Traumatic caroticocavernous fistula is also very commonly encountered thing, and many youngsters come with this caroticocavernous fistula. Most commonly they are driving or they are riding a bike and they have a trauma, and they get a traumatic caroticocavernous fistula. Usually patient presents with, see this right eye, there is severe chemosis. So they present with the triad of proptosis, which is pulsatile. So pulsatile, proptosis, chemosis, and ophthalmoplegia. So this is the angio picture. See that when the dye is pushed, the distal vessels cannot be seen. The whole dye leaks from the fistula into the cavernous sinus and to the superior ophthalmic vein. On the lateral view, you can see the dilated, aneurysmal dilatation of superior ophthalmic vein. This is causing the chemosis of eye. So this is the angio picture. See when the dye was pushed in the internal carotid artery, the dye is not going inside the brain. Whole blood is getting diverted towards the fistula. A schematic diagram to understand the physiology in such a case. The blood leaks from here, from the vessel into the cavernous sinus and goes towards the eye. So this is the post-coiling images. See now the angio, the distal vessels are nicely getting filled. This is a schematic diagram to understand how the coiling is done in these cases. Let's see a pre-procedure angio, and this is the post-procedure angio. You can see the coil mass here. Okay. This is the lateral view. The before coiling, you can see the blood is going retrograde into the petrosal sinus, sigmoid sinus, the cortical veins, the superior ophthalmic, inferior ophthalmic, even the facial vein in the late phase. But see, post-coiling, the blood is going where it is supposed to go. Another case, I'm not showing a video in this, just see the level of chemosis and proptosis in this case. This young 21-year-old male met an accident and he had a traumatic caroticocavernous fistula, and this is the angiographic images. See, the fistula was so high flow that contralateral cavernous sinus and contralateral superior ophthalmic vein was also filling. These are the post stenting images. This patient was very poor and could not afford coiling. Usually such cases need sometime 15, sometime 18 coils. So it goes very expensive. So in this case, covered stent was put covering the fistulous part. And this is the post-procedure eye. You can see the chemosis is relieved, his eye is opening and his vision was maintained. AVM is also a thing we see in younger people. A dictum is a young person presenting with spontaneous lobar bleed. There is a high chances that patient is having a AVM. So a young patient presenting with spontaneous lobar bleed, it's not, I'm not talking about an elderly patient presenting with basal ganglia bleed. This is a young patient presenting with a lobar bleed. It has a high chances of AVM. So this patient underwent workup and it was found out on angiography that he has a left temporal lobe AVM. Just to give an idea, this is a schematic diagram. AVM are congenital malformations. Usually the artery forms a capillary network and then there is a capillary network which drains in the venules and then the vein and then the superior sagittal sinus. In AVM what happens is there is a large nidus of these intermingling dysplastic vessels which forms the nidus. Aim is to take the microcatheter inside and embolize this AVM. This was our patient. This is the huge AVM on the left temporal lobe. The sagittal film of the same patient, see there is a huge blush, all the nidus we can see, and this is the post-embolization. Embolization in this case was done with onyx. This is the onyx cast. This can be seen in X-ray also and CT scan also. Okay, so such patients, they get relieved by endovascular embolization of this AVM, usually going for surgery sometime because it was on the left side. So doing a surgery on left temporal lobe may affect a young child's or a young growing person's memory and it may hamper with the learning disability. Thank you.
Thank you, sir. Any question?
Thank you, Dr. Salgodara, for enlightening on this exciting world of neurointerventions. Thank you very much. If someone has any question, he can answer maybe. So no questions. Thank you very much.
Thank you, sir.
Thank you.
Thank you.
Research has linked sitting for long periods of time with a number of health concerns, and we are concerned for your health. So please stand up and clap loudly for his lovely talk. Now I welcome you down the stage for felicitation, and I request Dr. Tapan Shukla sir to present memento to him. Now I welcome Dr. Manish Dabi sir on the stage for his talk on RFT, that is renal function test, everything you need to know. And I request the chairperson to introduce Manish Dabi sir.
Hello. Good morning, everyone. Welcome, Dr. Manish Davi, sir. He studied his DNB nephrology from Muljibai Patel Urology Hospital, Nadiad, in 2005. He started DNB nephrology program at Sterling Hospital. He is a DNB nephrology teacher since 2018. He started renal transplantation in 2013. His area of interest is preventive nephrology, maintenance hemodialysis, lupus nephritis, high-risk renal transplantation, and infection. Thank you.
Thank you, Chairperson, for kind words. Good afternoon, everybody. At the outset, I would like to thank organizing committee and scientific committee for giving this opportunity. I have been asked to speak about renal function test, which we should know. Now, I'll try to keep my slides very basic and to understand what we should do in our day-to-day clinical practice. Now, to start ball rolling, I'll start a case which we used to see in our clinical practice routinely. 78 years old gentleman with type 2 diabetes and hypertension on regular treatment and well-controlled sugars and blood pressure. Had history of fall in the bathroom and he sustained left fracture neck femur. Now, pre-operative assessment revealed creatinine of 2.2 milligram per deciliter, and then he was referred to a nephrologist for further renal evaluation and fitness for surgery. Now, there are many questions which we need to answer in this case. How we should evaluate renal function, whether this patient is fit for surgery or not, whether he requires further evaluation, whether this patient is at risk for getting acute kidney injury, and how to manage intraoperatively and postoperatively. Now, before discussing renal function test, let us discuss about which are the normal renal function. So primarily renal functions are divided into two: excretory function and synthetic function. So kidney acts as endocrine organ. By making urine, kidney gets rid of waste products and extra water, which helps in maintaining removal of toxins like urea, creatinine, uric acid. It regulates extracellular fluid volume, it regulates serum osmolality, acid-base balance, and electrolyte concentration. And by its synthetic function, it forms hormones like erythropoietin and renin, which help in maintaining erythropoiesis and blood pressure. It also synthesizes 1,25-dihydroxyvitamin D and regulates calcium, phosphorus, and parathyroid hormone, which is responsible for mineral bone metabolism. Why one should test renal function? So most of the time, patients with kidney disease have very fewer signs and symptoms, and in early disease, you can only tell about kidney disease by doing investigation or by laboratory evaluation. The ideally test should detect abnormalities early enough to allow corrective therapy. It is important for measuring renal disease progression and efficacy of therapy. It helps predict when patient will require renal replacement therapy, and renal evaluation is also important in appropriate dosing of modification, because the dose modification required as per renal function. Ideally, the test that best detect abnormality of renal function measure GFR, which is the surrogate marker of renal function. So basically, the renal function should have, renal function should detect renal glomerular function and renal tubular function. So renal glomerular function is measured by GFR, and generally good urine output will tell you about the renal tubular function, and this will give you some indication about renal blood flow. There are several clinical laboratory tests that are useful in investigating and evaluating kidney disease, but two important tests are: one, to evaluate GFR, and second is to check proteinuria, which will tell you about the patency of glomerular basement membrane. The GFR is the best indicator of glomerular function, and it is a rate in milliliters per minute at which substances plasma are filtered through the glomerulus. In other words, it is a clearance substance from the blood. The normal GFR is 90 to 120 ml per minute. Now, how to assess GFR? The GFR cannot be measured directly, and GFR remains constant under constant condition, but there are large variation in various individual, and there is a large spread of normal values because there are various variables like body size, sex, race, age. After age of 40 years, generally we lose GFR of 0.75 to 1 ml per minute. The pregnancy is associated with elevated GFR as much as 50% in first trimester. The protein intake, diurnal variation, antihypertensive therapy are other variables which affect creatinine. And lastly, there are few states which are associated with hyperfiltration like obesity, diabetes, and acromegaly. Now, to understand GFR, we have to understand the concept of clearance. The clearance is defined as the volume of blood or plasma completely cleared of a substance per unit time, and it is expressed as milliliters of plasma per minute. So for substance Z cleared by renal elimination, the simple formula is C is equal to UV upon P, where C is clearance, U is urinary concentration, V is urine volume, and P is plasma concentration. So if the substance is freely filtered at glomerulus level and it is neither absorbed nor secreted, then the clearance is equal to GFR. So ideally, the marker for GFR should have concentrate of production if it is endogenous. For exogenous marker, it should be delivered intravenously at a constant rate. It should be freely filtered. There should not be any tubular reabsorption or secretion. There should not be any extrarenal elimination or metabolism. There should be an availability of accurate and reliable assay because you need to monitor the renal function. And for exogenous marker, it should be safe, convenient, easily available, inexpensive, and it should not influence GFR. So we have exogenous marker in which inulin clearance is a gold standard. So all the GFR are generally measured after inulin clearance, but it is expensive and not widely available. So in clinical practice, we don't use inulin clearance. However, radioisotopes by 125 iothalamate and 51 EDTA will give you accurate GFR assessment, but they are expensive and you cannot do it repeatedly because it is quite expensive. Endogenous markers like creatinine and urea are very important, but if you want to calculate creatinine clearance, you need accurate urinary collection for 24 hours. It's time consuming and cumbersome. And urea has many confounding factors, so which is not ideal marker. So to circumvent this problem, people have come up with estimating GFR, that is eGFR, and you can calculate it by serum creatinine. Coming to the creatinine, which is the most important surrogate marker of renal function, easily available, and it is quite practical. The creatinine is generated in muscle by non-enzymatic conversion of creatinine and phosphocreatinine. It is proportional to muscle mass and it is relatively constant. It is the most used endogenous marker for the assessment of glomerular function. You can calculate clearance of creatinine by urinary collection, and it is calculated using the same equation, C is equal to UV upon P. And the latest guideline says that CKD EPI estimated GFR is the gold standard for assessing GFR. There are various factors which affect serum creatinine. A few factors which increase creatinine like ketotic stage, hyperglycemia, cephalosporin, flu cytosine, cimetidine, trimethoprim, exercise and ingesting cooked meat. Cimetidine and trimethoprim block tubular secretion of creatinine, so it will increase creatinine level. There are various other factors which decrease creatinine like dietary protein restriction, muscle wasting, malnutrition, and if you have done creatinine with Jaffe's reaction, bilirubin will interfere in the creatinine measurement. Advanced age, female sex and advanced liver disease are other factors which are associated with decreased creatinine. Now, creatinine alone is not a very useful marker because you can compare this two person, the 25-year-old gentleman with 85 kg weight, 190 centimeter weight with body surface area 2 and creatinine of 1.2. The eGFR is 106. But if you compare it with 80 years old frail elderly lady with 50 kg weight and 150 centimeter height, with the same creatinine of 1.2, the GFR is 38. So almost 1/3 of GFR with the same creatinine. So creatinine alone is not useful in measuring renal function. And if you can appreciate this chart, there is a correlation between GFR and serum creatinine concentration. Initially, the large change in GFR will not have much impact on creatinine. So if more than 50% GFR reduction is required to have some change in creatinine. So that is why in early renal disease, creatinine alone is not sufficient. In later on, you can see the small change in GFR will have much impact on serum creatinine level. There are various formulas are available to estimate GFR from creatinine. The first formula which came into the clinical use in 1970 was Cockcroft Gold. We still use Cockcroft Gold for drug dosage estimation. Then came MDRD, CKD EPI 2009, and latest is CKD EPI 2021. The change from CKD EPI 2009 to 2021 is that they have removed factor of race from latest estimating GFR, and the calculator for eGFR are available in internet. You can simply just put creatinine and age and you will get estimated GFR. From GFR, there are various stages of CKD. The definition of CKD is presence of kidney damage or decreased kidney function for more than 3 months, and either you have reduction in GFR or you have some evidence of kidney damage by radiological assessment or urine analysis like presence of proteinuria or sediment. In stage 1, when your GFR is more than 19, you have some evidence of kidney damage. Stage 2 is when GFR is between 60 to 89. Stage 3 is divided into A and B. A when your GFR is between 45 to 59, B is from 30 to 44. Stage 4 is when GFR is between 15 to 29, and stage 5 or the stage of ESRD when GFR is less than 15 ml per minute. Though urea is very frequently used as a marker of renal function because it was the first indicator to use measure of GFR, but it has very few features for ideal marker because it is heavily reabsorbed in the proximal and distal nephron, and reabsorption is substantial in states of decreased renal perfusion. It is variable and largely depend on protein intake, and there are various factors which affect serum urea nitrogen. Serum urea nitrogen can be derived from by dividing urea upon 2.1428. So though we may use urea clinically, but urea is a very poor marker, and creatinine is better marker for GFR assessment and renal function measurement. The urea is useful when you want to differentiate pre-renal versus renal, because when the patient is in dehydration state, urea will rise disproportionately. So urea by creatinine ratio more than 40 generally is suggestive of pre-renal acute kidney injury. Now, as we discussed, there are various problems with creatinine and urea because there are various factors which affects its metabolism, and there are various factors which affects its assay. The cystatin C is a newer marker for renal function assessment. The molecular weight of cystatin C is 13,000 Dalton. It is proteinase inhibitor, and it is produced by almost all nucleated cells at constant rate. It is freely filtered and then absorbed and catabolized by renal tubule. There is no significant urinary secretion. The normal adult values ranges from 0.54 to 1.5. Many studies have shown that it is better marker than serum creatinine because it is not affected by age, muscle bulk or diet. In early renal dysfunction, probably it is better marker than creatinine. And CKD API has also incorporated cystatin C in eGFR equation. Now the second important evaluation for renal function is urine analysis. Our professor used to say that urine analysis is not the investigation, it is a part of clinical assessment. Because by analyzing urine characteristic as a step in the disease diagnosis process, it consists of physical observation, chemical and microscopic examination, and the physical inspection involves assessing color and clarity. The urine color will give you many ideas about underlying disease, like high color, yellow urine will tell you about bilirubinuria or B complex intake. Smoky red is generally related to presence of blood in the urine. Brownish red is generally associated with hemoglobinuria. The orange urine is either because of high level of bilirubin or rifampicin consumption. Red urine is generally suggestive of porphyria of ingestion of red bit. Black urine either alkaptonuria or formic acid poisoning, and milky urine is suggestive of chyluria. The simple dipstick will tell you about many things. The 2-3 most important thing in dipstick is specific gravity, pH, protein, and nitrate and leukocyte esterase. The specific gravity and the pH of urine will tell you about the tubular function of kidney. When you have renal tubular dysfunction, generally the specific gravity is low. When you have status like polyuria, generally the specific gravity is low. Inadequate water intake or volume depletion will lead to high specific gravity. When you have acid-base disorder and defect in renal acidification, generally the urinary pH will be on higher side, on alkaline side. Presence of nitrate and leukocyte esterase is quite sensitive as far as urine infection is concerned. Now, albuminuria and proteinuria is very important because this will tell you about the increased glomerular permeability or breach in glomerular basement membrane. Albuminuria refers to the abnormal presence of albumin in the urine. Initially, we used to use a term microalbumin, but nowadays we don't use microalbumin because there is nothing like microalbumin like molecule. Albuminuria is used as a marker for the detection of incipient nephropathy in diabetes, because in early diabetic nephropathy you will only have albuminuria. The presence of albuminuria on 2 occasions with the exclusion of UTI indicate glomerular dysfunction, and normal urine protein is up to 150 milligram per deciliter. Now, why you need proteinuria assessment? Because determination of proteinuria is an important screening test for identifying kidney involvement in various diseases, especially systemic disease. It is a crucial prognostic factor for the development and progression of CKD. Higher the proteinuria, higher chance of CKD progression. It is independent risk factor for the occurrence of cardiovascular disease, ancestral disease, and death. The normally urine protein is less than 150 milligram, in which albumin is less than 30. The rest protein in urine is consisting of TEM hostile protein, blood group related antigen, hormones, enzymes, and immunoglobulin. Albuminuria can be classified in category A1, A2, A3. Now A2 is between 30 to 300, which initially we used to classify as microalbuminuria, and A3 is when you have more than 300 or severely increased albuminuria. Now when you see or when you detect protein in urine stick, it should be followed by quantitative urine protein assessment. Now the gold standard of quantitative urine protein is 24-hour urine protein, but it is cumbersome and it can lead to erroneous protein estimation if you do not have collected 24-hour urine properly. So protein creatinine ratio has replaced 24-hour protein now, because if you can see, there is a good correlation between protein excretion over 24-hour and total protein creatinine ratio. But clinically, when you are assessing proteinuria, ideally you should get 24-hour urine protein first, and then monitoring of disease can be done with urine protein creatinine ratio. Urinary microscopy is very important because there are few pathognomonic changes. Like if you see red blood cell cast in the urine, it is suggestive of glomerulonephritis. If you see white blood cell cast in the urine, it is suggestive of either pyelonephritis or interstitial nephritis. The presence of granular cast and hyaline cast is suggestive of acute kidney injury. The presence of broad cast, which generally tell you that the tubules have dilated, it is suggestive of chronic kidney disease. There are various crystals which are found in urine. I will not go into the detail, but the urine crystal is very important in renal stone disease. Now, when you have disorder of electrolytes or acid-base disorder or osmolality disorder, you have to assess tubular function. I will not go into the detail, but there are various tests for identifying tubular function, like urinary specific gravity, urinary osmolality, renal concentrating capacity, which can be proved by water deprivation test, renal diluting capacity, urinary acidification when you are dealing with acid-base disorder, particularly renal tubular acidosis, in which there is defect in acidification. So urinary pH will be high, there will be altered urinary anionic gap, and there will be high urinary osmolar gap. And lastly, urinary electrolytes when you are investigating a case of potassium disorder. Assessment of tubular function in ARF is useful when you want to differentiate between pre-renal and renal. In pre-renal, the urinary specific gravity will be high, urinary osmolality will be high, urinary sodium will be less than 20 because there will be effective blood volume depletion. The fractional uric acid will be less than 7, and there will be low molecular weight protein and beta-2 microglobulin will be low. Other relevant tests which requires in evaluation of kidney function are serum electrolytes, calcium, phosphorus, parathormone hormone, vitamin D, iron studies, renal imaging, immunological workup and viral markers, and lastly, if indicated, renal biopsy. Now, as we discussed that creatinine is not the ideal marker, especially in early renal disease. And the equations for eGFR is only valid when patient is in steady state, stable condition. When the GFR is changing frequently, you can't apply this eGFR formula. So the person with acute kidney injury, creatinine is useless. Because when patient has reduction in urine output or rise in creatinine, you are already late because the acute tubular necrosis are already sets in. So there are various new biomarkers are available which are useful in AKI because it will tell you about the early tubular damage. These are NGAL, kidney injury molecule, L-type fatty acid binding protein. There are various papers, but unfortunately it is still too early from bench to bedside, and in the future probably we'll get better markers. So lastly, the normal and critical findings of GFR. The normally GFR should be between 90 to 120. The presence of normal GFR does not exclude the presence of renal, because there can be presence of albuminuria or there can be some problem with imaging. A rapidly increasing serum creatinine is considered rapidly progressive renal failure, which requires immediate nephrological consultation. And the GFR of less than 15 ml per minute is end-stage renal failure, and which require renal replacement therapy. Thank you.
Excellent talk, Dr. Manish Davi, and very timely concluded also. Thank you for that. If someone has any question, he is there to answer. Any questions from the audience?
Okay, so
Thank you, Dr. Abi. Thank you.
Okay, ચલો ઊભા થાઓ અને તાળી પાડો ફટાફટ. Thank you, Dr. Manish Dabi, for value addition, excellent talk. Now, I welcome you down the stage for the felicitation, for which I request Dr. Piyush Waghela to present the memento to sir. Now, I welcome Dr. Rajiv Bhatt sir on the stage for his talk on breast cancer diagnosis and treatment. What has changed? And I request the chairperson to introduce Dr. Rajiv Bhatt sir.
Good morning, everyone. Dr. Rajiv Bhatt is known to most of us, but at least for delegates who are coming from far and wide, it's my pleasure to introduce Dr. Rajiv, alumni of Tata Memorial Hospital, Mumbai. He had several fellowships at very reputed centers like Memorial Sloan Kettering and Nottingham in UK. Very great academician. He had a lot of publications, lectures, orations, and a vast experience of more than 3 decades in surgical oncology. His area of interest is breast surgery, and he has a team of oncosurgeons. He is a great entrepreneur as well. So I present to you Dr. Rajiv Bhatt. Thank you.
Thank you very much, Dr. Bhikubai, for those kind words of introduction, and word of gratitude to Drs. Mitesh, Pragnesh, Mehul, Neeraj, Samir, the entire organizing team of Gimacon for inviting me here to give this talk. Breast cancer now is the commonest cancer worldwide, and in India, it forms 13.5% of all the cancers that we see. There is increasing incidence, but along with that, there's also very high mortality. And in India today, we are looking at almost about 240 breast cancer related deaths every day. That is the equivalent of an Airbus crash every day. That's big news, but we pay scant attention to it. Now, our breast cancer is very different from that which is seen in other countries. If you look at the incidence, our incidence is much lower. It's 1 in 25 women in urban areas. The mortality, however, is one of the highest in the world at 1 in 2. And there's a lot of questions as to why there is a high mortality from breast cancer in India. And clearly, the major reasons are the late stage in diagnosis, delayed initiation of definitive treatment, often the suboptimal, inadequate, and fragmented treatment that patients are subjected to. Now, the only way that we can revert this is by applying the maxim that early detection does save lives. And if detected in early stage, that is stage 1 and 2, we have upwards of 90% cure rates as compared to stage 3 and 4. And how do we do this? We don't have a population-based screening recommendation for the country. What we do advise is awareness-based early detection, and this just means increasing the awareness, providing disease-specific information to people, encouraging women to do a BSc every month, asking them to undergo a clinical breast examination at periodic intervals, and not neglecting their own health. This is one of the biggest problems in India, that women tend to neglect their own health in favor of looking after their children and the husband and the rest of the family. And unfortunately, the awareness is really low. Less than 10% women in our country will practice breast self-examination. Now, coming to another change, the increasing use of genetic testing for breast cancer. And now, actually, it is universal. You'll find that the current recommendations demand that less than 50 years age women who have breast cancer, those with triple negative breast cancers, bilateral or metastatic breast cancers, all of them should be tested genetically. And this is a big change from what we were doing a few years ago. And the reason is very clear for us to see. About 5 to 10% of breast cancers are hereditary, and essentially these are the BRCA1, BRCA2 genes, and there is a very high incidence of breast and ovarian cancer when one has both these genes, and this is now very easily available almost everywhere for us to test. Now, as far as the risk factors are concerned, obesity has replaced tobacco as the main lifestyle related cause for premature death. And one of the major risk factors for breast cancer is obesity. And this is true in postmenopausal breast cancer. As an example, a 5% increased risk of breast cancer will accrue to every 2 increment in BMI. And this is huge. The important thing is that you can have a normal BMI and yet have an increased risk, because BMI does not distinguish between fat and muscle. So adiposity is essentially what we are looking at. The silver lining here is that intentional and sustained weight loss can reduce this risk. So a simple 5% weight loss reduces the risk by 12%. And mind you that survivors of breast cancer also have a 50% increased risk of recurrence or a second malignant neoplasm if they are obese. So clearly this is very important, and we know that this is mediated now by multiple endocrine routes. You know, fat is the largest endocrine organ in the body, and the estrogens and insulin-like growth factors, adipocytokines, all of these mediate the increase in the cancer risk for these patients. The other change is that traditionally we used to treat anatomically, essentially how much the cancer has spread, which areas it has spread to. Now we identify specific biological subtypes, and essentially this gives us an entire spectrum of cancers, ranging from the ones with an excellent prognosis to ones with the worst prognosis. And we classify 3 categories. One is the hormone receptor positive woman, the second is the HER2 receptor positive woman, and the third is the triple negative, in which neither of these receptors will be positive. And if one looks at the outcomes, they are clearly different for all of these. And you will clearly see that the HER2 positive and the triple negative have a worse outcome compared to the hormone receptor positive. So biological subtypes do matter. And in fact, the more the stage, the more does it matter, because the graphs tend to separate in stage 3 and 4. In early stage breast cancer, it might not matter as much, but in advanced stage breast cancer, it is critical. What has changed in the diagnosis? Now we know that the clinical examination and bilateral mammography and ultrasound is basic. What has altered is that previously FNAC was an acceptable method of diagnosis. It's a cytological diagnosis, and we don't recommend it be done now. The gold standard for diagnosis now is clearly a core needle biopsy, and there are 2 reasons for this. One is that it gives almost negligible false negative rates. The second is that we can determine the IHC4, the ERPR, HER2 neu, and Ki67, which is a proliferation index, on the biopsy material. And we need this prior to initiating treatment, irrespective of what kind of treatment we are going to subject the patient to. Simple excision or an excision biopsy should never be done, and I mention only to condemn it, because it causes immense problems in the subsequent treatment, because at least 30 to 40% of these patients will come back with positive margins, and then it becomes really difficult for us to do any meaningful treatment. As an example, you can see this woman, very clearly demarcated lesion on mammography, and she ends up with this kind of an excision biopsy, which puts us at a lot of problems in trying to plan the subsequent treatment. What about surgery? What has changed? Well, this was the traditional thinking, that we would do primary surgery in all cases, that mastectomy is the gold standard, and that we would do an axillary lymph node dissection in all cases. What's the situation today? None of this is true. Previously, the patient would go to the surgeon, and the immediate thinking would be surgery should be done immediately after the diagnosis, do it as quickly as possible, stop the disease from spreading to the rest of the organs. Nothing could be further from the truth. Now, primary surgery is one option. The second is to provide some kind of a systemic therapy up front, either chemotherapy or endocrine therapy, more often chemotherapy combined with some kind of monoclonal antibody or immunotherapy. Now, primary surgery is what is advised for all early breast cancers. Early breast cancer is a tumor that's less than 5 centimeters with very limited nodal disease. And in selected cases of advanced breast cancer means tumors that are larger than 5 centimeters, or they involve the skin, they may involve the chest wall, or with extensive lymph node involvement in the axilla. But even there, based on the biology, we would still do upfront surgery for hormone receptor positive cases and women above 70 or 75 years of age. But in all other cases of advanced breast cancer and in early breast cancer who are HER2 positive or triple negative, we would want to give upfront chemotherapy. And this has been a significant change from previous years. So now the teaching is that surgery should be done, but at the right time, in the right patient. Begs the question that is breast conservation treatment safe? And now we have more than 25-year follow-up on 8 of the key randomized trials showing that essentially the survival is exactly the same whether mastectomy is done or whether breast conservation treatment is done. So the answer to that question is a simple yes. Breast conservation surgery means removal of the lump and doing axillary dissection, and this is what we used to do in the last decade. This is one of my own cases, but you can see the suboptimal cosmetic outcome. There is depression and saucering here, a large scar in the axilla, but this was standard breast conserving treatment done in the last decade. What we have now progressed to is doing oncoplastic breast surgery, which essentially allows rebalancing of the breast tissue. It's a combination of adequate oncological clearance, keeping in mind the aesthetics of plastic and reconstructive surgery to give a cosmetically meaningful breast. And either we will do some form of a volume displacement or a replacement. There are multiple procedures available depending on the location of the tumor in the breast. This is one just such example, and this is another one for an inferior pole tumor. And you can see over here that the tumor is removed, it's marked, oriented adequately for the pathologist to do a proper pathological examination on. And this is the ultimate outcome, a cosmetically acceptable breast. And these are other kinds of oncoplasties, one for the lower inner quadrant, one for the upper quadrant. This is a case which had a very large, almost hemi-breast tumor in the upper half of the breast, but she had a very large breast size that allowed us then to subsequently remove the tumor adequately and reshape the breast to give a cosmetically acceptable result. Another technique is a round block technique. This patient had an associated axillary dissection, and you can see that our scars have become much more acceptable now. This is one with sentinel lymph node biopsy. You can hardly appreciate the incision in the axilla. Even after radiation, the results are cosmetically acceptable. Sometimes we have to do volume replacement if the patient has a small breast. An example of a latissimus dorsi, a mini LD reconstruction, we call it, and this also gives fairly acceptable results. Now the issue is that if we have given upfront chemotherapy, is it safe to offer the patient breast conservation treatment? And this is one of the recent papers which clearly said that when corrected for confounding cofactors, breast conservation treatment offered an approximately 5% survival benefit. So not only was it equal, it was superior. Another study with large tumors more than 5 centimeters, almost similar results, mastectomy or breast conservation treatment. So if we compare either of these, then clearly breast conservation treatment, the survival is equal or better, the quality of life is much, much better. When is mastectomy acceptable? When there is extensive or multi-invasive disease, multi-site disease, second cancer, prophylactic risk reduction surgery, or by patient choice. Now, patient choice is a very precarious thing. I often have patients coming in and they have well-meaning doctor friends and relatives who have advised them, no, please remove the breast completely because if you leave it there, it's going to come back. And all this is born out of only one thing, it is fear. But this fear, as far as I am concerned, is not a good indication for mutilating surgery. And the patient needs to be counseled adequately. This is not the case. If after that they still want a mastectomy, then so be it. This is a meta-analysis showing that after a neoadjuvant chemotherapy, it is completely safe to do a breast conservation surgery. We can convert approximately 20 to 40% cases from mastectomy to a breast conservation after giving neoadjuvant treatment. The goal is to try to achieve complete eradication of the tumor and the disease in the axilla. We call this a pathological complete response. Patients who have a complete response will have a much improved survival compared to those who don't. Surprisingly, the PCR rates are very different for the different subtypes of breast cancer. Many times I get asked the question that if there is a complete response, then do we need to remove the tumor? The answer is yes, because 30 to 40%, 50% will still have residual tumor. As surgeons, we have a problem finding the tumor if there has been a complete response. How do we find it? We localize with these small clips prior to initiating neoadjuvant treatment, and after the neoadjuvant chemotherapy, we excise the portion that has that clip, confirm with the specimen mammography that the margins are adequate and the clip has been completely excised. Negative margins are a prerequisite for BCS, and to ensure that we do specimen mammography and frozen section, mark the tumor, and we get the report back in about 20 to 30 minutes. This is the kind of response that we see with upfront chemotherapy in locally advanced breast cancer. And this particular lady, young with triple negative breast cancer, had an excellent response. She undergoes an oncoplastic breast surgery, and the residual tumor is less than 1 millimeter. Our experience at HGG has been that now we are doing more breast conservation surgeries than we are doing mastectomies for all stages. The graphs crossed over about 2 years back. Even after neoadjuvant chemotherapy, we are now doing more conservation surgeries than we are doing mastectomies. Coming now to management of the axilla, we now have two options: sentinel lymph node biopsy and a formal axillary lymph node dissection. And axillary lymph node dissection is mandatory for women who have radiologically or clinically positive nodes in the axilla. We remove levels 1 and 2, but there are certain complications, and this is the one that is the most feared. About 20 to 40% of women will have lymphedema. To obviate that problem in women who don't need it, radiologically negative lymph nodes in the axilla, we do a sentinel lymph node biopsy, frozen section, and axillary dissection only if the node is positive. What is a sentinel node biopsy? We try to find the sentinel lymph node, which is the first draining echelon lymph node of the tumor, and if that is positive, it is likely that the higher level lymph nodes are positive. How is this done? We do it by a fluorescent image guided surgery, ICG, where with an infrared camera, we are able to actually look at the node, and then this is a very small 3 centimeter incision, and we will pick up the node and submit it for frozen section. This shows the stained node. That shows the very small 3 centimeter incision that we would take, and this is a node that we would excise and submit for frozen section. This is a real-time picture of the infrared camera and the image-guided surgery. That's the monitor which we use to guide our surgery. Sentinel lymph node biopsies now we are doing quite frequently, and we've done about 122 with this technique now. Finally, coming to distant metastases, now we treat metastases with curative intent. The reason is that we can detect these earlier, we characterize the disease more specifically, and the 5-year survival rates are still very good. Almost 27% of women will survive 5 years or more. But here again, all metastatic disease is not the same. We identify oligometastatic disease, and you can see that the survival is different based on the biological subtype after that particular treatment. Just to give a very quick example, this is a 62-year-old female who had an early breast cancer, and the routine imaging showed a liver lesion that was biopsied, showed a metastasis. She received upfront chemotherapy, and post-chemotherapy she had breast surgery. She declined surgery to the liver because there was no residual tumor seen in the liver, although we did insist that she should have that segment removed. She then completed 12 months of monoclonal antibody. A year down the line, she was still free of disease, but 2 years down the line, she comes back with this disease in the liver, which wasn't a surprise at all. We did a biopsy, again confirmed it to be a metastatic breast cancer. She received chemotherapy and subsequently underwent a right hepatectomy of the involved lobes, and 3 years down the line now she is free of disease. As far as systemic treatment is concerned, we tend to underestimate the benefits. In fact, the single most advance in the last decade has been the improvement in survival with chemotherapy. And the main reason why people fear it is the side effects, but this is really more in the mind than it is a reality. We now give combination chemotherapy, and a lot of cocktails are now available combining chemotherapy with hormonal agents, immunotherapy, and all the other stuff that's available now in the market. But one thing is very clear from all this, that one size does not fit all. Every woman's breast cancer is different. In an era of personalized medicine, now we have to see that we intensify treatment in appropriate cases and that we de-escalate treatment in other cases. The only way that we can do this is to have regular MDT meetings and decide each patient's treatment so that we give the right care for the right patient at the right time. For me, the simple thing that has changed is that we now appreciate we are not treating breast cancer. We are treating women. Thank you very much for your attention.
Thank you, sir. Any question?
Excellent, Dr. Rajiv. It was really very good, and we have come a long way in breast cancer. If anyone has something to ask, Yavisi.
Is male breast cancer different disease entity and prognosis, treatment strategy, or it's a more or less similar and much early detection because of less tissues?
Yeah, the thing is that, we often detect it a little later rather than earlier because males don't appreciate that they can get a breast cancer. It's 200 times more common in women than it is in men. But otherwise, it essentially is an endocrine-based disease. A large number of male breast cancers will be hormone receptor positive. So paradoxically, they have a slightly better prognosis than they would have for, say, younger women with triple negative breast cancers.
Rajiv, I have a question. So what do you believe about certain equipments for screening, like some thermographic images which are to screen, for CA breast screening? So what is your
No, I think, look, the gold standard still is mammography and ultrasound. Thermography really is a very primitive and a crude tool to be used only in mass camps to detect lumps that need further investigation.
So not
it's
on a
not
hospital
a diagnostics
setting.
tool, no.
Thank you very much. Thanks a lot.
Thank you, sir. Now I request everyone to stand up and give a very big round of applause for sir. It was an excellent talk, sir. Now I welcome down the stage for felicitation and I request Dr. Bhikhubhai Patel to felicitate sir. I welcome all chairperson down the stage for felicitation, for which I welcome Dr. Vinod Chaudhary sir, Dr. Samir Contractor sir, and Dr. Neeraj Chawda sir. To chair the next session, I invite Dr. Mehul Desai sir, Pragnesh Shah sir, Dr. Arpan Shah on the stage. Dr. Mehul Desai is a practicing clinical pathologist and honorary secretary of IMA Vadodara. Dr. Pragnesh Shah sir is a clinical cardiologist and organizing secretary at Gimacon 2022. And Dr. Arpan Shah is a leading pulmonologist in Vadodara. Now I welcome Dr. Professor K.R. Balakrishnan sir on the stage for his talk on lung and heart transplant, surgery, survival and more. And I request one of the chairperson to introduce sir.
Hello. Thank you, sir, first of all, for sparing some time for IMA Gimacon from your busy schedule. And friends, let me tell you that we all are very, very fortunate enough that sir is here to give his talk. Dr. K.R. Balakrishnan is basically a Director, Cardiac Sciences and Chief Cardiothoracic Vascular Surgeon at MGM Chennai. He has been instrumental in developing India's first comprehensive heart failure management program. And he is also the first cardiothoracic surgeon to develop to do the first LVADs and HVAD pump implants in way back in 2012. He is a co-inventor alongside Dr. Albert as one of the new models of heart valve prosthesis. Along with his great expertise in treating congenital complex cardiac cases. He runs one of the most high-volume centers for transplant in India. They have performed, as of now, more than 500 heart and lung transplants. And year on year, the numbers are increasing and the success rates are fantastic. So without wasting much time, I would hand over the mic to sir. And sir, we would want next 35 minutes from you to be very scintillating. Thank you.
Thank you very much and good afternoon. It's a great honor for me to be in your wonderful city, and I appreciate this opportunity to be here with all of you today. I'll speak about the current status of lung and heart transplant, and I'll use the different set of slides instead of combining the two together. I'll start with the lung first. The history of lung transplant or attempts at lung transplant, this might be of some interest to all of you. Dates back to 1948 when a young Russian surgeon attempted and had a surviving lung transplant for 7 days in 1948, which is a century ago almost. The interesting thing is he is a mad scientist, but was the first in the world to transplant the head of one dog into another, and you can see both of them drinking milk. So human life is strange, and Russia at that time was a powerhouse of knowledge. The first attempt at lung transplant was by Dr. James Hardy at the University of Mississippi in Jackson for a patient with lung cancer on one side, which was involving the right main bronchus. So that patient required a pneumonectomy, and the other side had COPD. So this was done way back in 1964, and this patient survived for 18 days and eventually died of renal failure. And you must be appreciative of the fact that it was remarkable when there's no CT scan, bronchoscopy was primitive, we didn't have immunosuppressants for this to be possible. Over the next 20 years, approximately 40 lung transplants were attempted and none were successful. Most of the time, the bronchial anastomosis was the problem. And it was only in 1989 that in the University of Toronto, the first successful unilateral lung transplant happened. And soon thereafter, people started doing bilateral lung transplants and the modern era started. And it's one of the fastest growing specialties now, especially with the advent of donation to circulatory death. And as you can see from this graph, the number of lung transplants is growing very steadily. In this country, cadaveric organ donation started way back in 1994, but till the year 2010, the progress was very slow because of a lack of an organized donation. And the year 2010, we started transplanting in a significant number, and over the last decade, the numbers have grown. And we now currently have done over 120 lung transplants in our experience. The vast majority of lung transplants in India have been performed in the city of Chennai. The interesting aspect is if you draw the majority of donors in this country happen south of a line drawn across the middle of India from Gujarat on the west coast to Visakhapatnam on the east coast. 95% of donations happen below that line. Because of the activities of NATO and national organ donation activities, we have close to 1,000 donors a year. When a patient is referred for a lung transplant, and those are patients who are steadily on decline despite maximum oxygen and they are not able to walk, they are respiratory cripples. At the same time, their other organs are well preserved. So very briefly, most of the donors are road traffic accident victims, and we ensure that the lung function and the oxygenation is adequate. The donors are not smokers, the lung is not injured during the road traffic accident, and there is no infection or aspiration. And the lung is harvested as a block, as you can see here. And the recipient operation involves cutting across the sternum, and this is how the field looks after both the lungs are removed. And very briefly, we split the lung block into two by dividing the pulmonary artery and the pulmonary veins and the bronchus. And the two blocks are then implanted individually into individual lungs. You push the lung in. It's technically quite an easy operation to do. As you can see, we first do the bronchial anastomosis. These are big structures, so we use 4-0-proline, and it is a straightforward procedure in terms of actual suturing. After that is done, the pulmonary venous anastomosis is done. The entry of the pulmonary veins into the left atrium is clamped. You incise the confluence of the pulmonary veins, and it's again anastomosing donor lung to the recipient lung is done in a straightforward fashion. And the final anastomosis is the pulmonary artery. And at the end of the operation, the lung should look like this. Both the lungs are deflating very well and the oxygenation is excellent. And by and large, these patients do very well. The challenges that we had to overcome is increasingly the donors are from all over the country, so long distance procurement is a problem. Most of the organs are now harvested using commercial aircrafts. So we put it in a box like this and go through the security check. We have to buy a separate ticket for the heart or the lungs, and this is a patient who received a heart and lung transplant, so the end is worth it. So we were the first in the world to use commercial airlines. It is not common in this country. It is not used in any other country in the world. As you can imagine, to hire a private jet for every organ transfer is prohibitively expensive. And we published this in the Journal of Heart and Lung Transplant. And as you can see, compared to a private jet, the cost is 10 times less. Transporting patients is an even bigger problem, especially during COVID. All of you would have seen patients were airlifted to centers where ECMO was possible. And most of the time, this is the kind of private jet you get. The door is narrow. You can't even shift a patient with a stretcher inside. You can't turn the patient in. The power supply is erratic. Very often the power comes on only a half an hour after the plane is taken off. And these are huge challenges. But we have, especially during COVID, close to 250 patients were transported to our center from different parts of the country and different parts of the world, as a matter of fact. So we gained a very large experience in transporting patients on ECMO. So we have transported using three means, either on ambulance or an ECMO or train ambulance. So long distance transport is possible. Where patients can afford, we use an ambulance like this on a patient on ECMO. The longest we have transported is from actually Siberia, where the flying time was 18 hours. So it is possible to transport patients over long distances. The Indian Railways gives you an intensive care unit in a flight. It's much less expensive for patients who are not critically ventilated or on just inotropes or on oxygen. So the other challenge was to keep sick patients alive while an organ is being awaited. Even though the organ donation rates have increased, a given blood group may not be possible. So we use ECMO. This patient was in ECMO for 45 days awaiting a lung transplant. And this is him soon after the surgery, and that is him 5 years later. So excellent long-term outcomes are possible. These days we learn to mobilize these patients, and the data I'm showing will be useful to you because a lot of you are intensivists, and this is no longer an experimental treatment. ECMO is the reality, and in my opinion, every city should have at least 1 or 2 ECMO centers. It's possible to save lives because even though COVID has disappeared, we now have H1N1, and every year we are going to have some new epidemic or the other. Infections are a big issue, and we can mobilize these patients and keep them alive for as long as 3 or 4 months. And the question is, in patients with severe pulmonary hypertension with heart and affection, whether we should do a heart and lung transplant or lung alone. And by and large, this child with severe pulmonary hypertension had a lung transplant, and she's doing well. The outcomes are, historically, compared to all other organs, the outcomes were not as good for the lung as compared to the heart, with a 5-year survival of around 60%, but now it's increasing, and currently our 1-year survival is over 90% for lungs. Living donor lung transplant, lying a living donor heart transplant, liver transplant is possible. You need 2 donors, one lower lobe of each donor is used, typically from a parent to a child. This is very commonly done in Japan, where because of their religion, organ donation is not common. You need 3 operating rooms, so 2 lobes from 2 adults are used and put into the recipient. And the outcomes have been excellent. There are complications of lung transplant, like complications of any other operation, graft dysfunction, infection, rejection. So this is an example of bronchial dehiscence on a patient who was in ECMO for a long time. 1 month after the anastomosis, as you can see, the bronchus is narrowed and dehisced. So you can put in a stent, and open up the bronchus, and the stents are life-saving with excellent outcomes. We've had dehiscence of the tracheal anastomosis in a heart-lung transplant, in which case we put a bifurcation stent. The functional outcomes are excellent. The girl to my right is from Arunachal Pradesh, and this is her 5 years after a heart and lung transplant, living a normal life. A 73-year-old woman who was a respiratory cripple shifted to us from Chandigarh on a ventilator. After a single lung, within 2 months, she's able to walk, and she's alive now after 4 years of transplant. This man was on ECMO for 70 days post-COVID with a completely destroyed lung. And within 1 month after the transplant, he's walking around with lung. So lung transplants are life-saving. We have also done pediatric lung transplants. This is the first pediatric lung transplants in India. This child was shifted to us from Moscow and Russia on a ventilator at the age of 3 months. And she was waiting in our city for 3 years on ventilator. You can imagine how difficult it is to keep a child on ventilator, on tracheostomy for 3 years, anywhere in the world, and especially in this country. And eventually she got an organ, actually from Surat. And this child did very well. This is the child at the end of 2 months. So lung transplants, as you can see, can be life-saving. So the current status of lung transplant is, as I said, we do close to 100 lung transplants, 100 to 150 lung transplants a year. And the outcomes are excellent, with 1 year survival of 90% and 5 year survival of close to 75 to 80%. I should now come to the status of heart transplants in India. So from October 2012 till date, we have done a total of 540 odd transplants, out of which 440 have been heart or heart-lung. The majority of patients are sick because by the time they are diagnosed and they are referred and the patients agree for surgery, they're very sick, they have renal dysfunction, their creatinine is high, very often they are jaundiced. ECMO and Centrimag are the mainstays of mechanical support because when they are referred, you don't always get an organ. Patients who have renal failure, awaiting a kidney transplant, the advantage is they have dialysis to keep them alive. The equivalent of dialysis in heart is inotropes or mechanical pumps. Pediatric organs are scarce, so if you have a child requiring a transplant, very often we use adult hearts. Again, to overcome waiting list mortality, we still use ECMO extensively, including this 85-year-old man who had a cardiogenic shock, had a cardiac arrest, and recovered completely after angioplasty after 3 weeks of ECMO therapy. So we use ECMO across age groups. Sometimes after ECMO, the hearts can recover, like this child with viral myocarditis. This young boy was in ECMO for 6 weeks and eventually underwent a transplant, and this is him after 2 years. And this boy from Russia was on ECMO 3 times in the course of his hospitalization for graft dysfunction, and this is him after 3 years doing very well. This young woman of 34 was airlifted from Delhi on ventilator, sustained a cardiac arrest, was put on ECMO for 3 weeks, received a heart, and 5 years later she's able to ski in Gulmarg and climb Vaishnav Devi on foot. So ECMO, as I mentioned, is life-saving, and in my opinion, it should be there in every city, at least one center. This young girl, again, is an example. She was airlifted from Delhi during COVID times when the organs are scarce. She had sustained a cardiac arrest. She was put on ECMO and then 2 pumps to support the heart. We got an organ from Surat, which is from a patient who has sustained a stroke because of cerebral bleed. This patient was hypertensive, and as you can see, ventricle is very hypertrophied. So the ischemic time was long, and by the time the heart came to us, it was not beating much. So she was supported on ECMO for almost 10 days after the transplant, and the heart completely recovered. And this is her at the end of 1 year. So we've used impeller pump also in children, and I'll skip all. The youngest we have done is, I think, 4 months old. Long-term heart pumps are available now. These can function for 15, 20 years as a substitute for transplant. They are expensive. Unfortunately, they cost close to 70 lakhs, which is not affordable for a lot of people. But for those who can afford it, it's a substitute for transplants, and you can have an excellent long-term survival. This girl is now arrived, she's now 4 years post-transplant, and this boy is alive 9 years after transplant, after an LVAD implant. And this is the youngest child we have done, 4 years. At the age of 4 years, she received an artificial heart. I have covered transportation. The outcomes of heart transplant are excellent. The 90-day survival in our series is around 85%, which compares very favorably with the International Society of Heart and Lung Transplant outcomes that is published. And the risk factors for early mortality are patients who are sick. Intermax is nothing but a functional class. So those who are referred in cardiogenic shock or in pre-arrest situation have a higher risk. Patients with significant renal dysfunction have a higher risk of mortality. And that is true for international results as well. We now have a 10-year follow-up of transplants in this country, and more than 55% are alive at 10 years, which again is equal to what is published internationally. If the age is less than 18, the 10-year survival is over 65%. If the age of the patient is less than 40 years of age, the 10-year survival is around 60%. So excellent long-term results are possible. And we have published this in the Indian Heart Journal and the Pediatric Journal. The functional outcomes are excellent. This man was shifted to us from Bombay on ECMO after cardiac arrest. He is now the CEO of a 2,000 crore company. Extremely successful businessman, 7 years after a transplant. This man from Calcutta, 5 years after a transplant, finished first in a half marathon in an open field. That's the kind of functional activities. These two children are recipients of a transplant of heart. You cannot even make out that they are heart failure patients. The girl to my left is actually from Gujarat. I met her 4 years after a transplant while we were trekking in the mountains of Munnar at an altitude of 5,000 feet looking for mountain goats. Suddenly somebody called out my name. It turned out to be that girl, and 1 year before she was in ECMO awaiting a heart. So they become virtually normal. This girl in the foreground had a heart transplant 3 years ago. She's now practicing to become a tennis player. This boy to my left, he's actually from Ukraine. We did a transplant 6 years ago. Till the war happened, he was playing football for the national football team. So they become virtually normal after a transplant. So in conclusion, excellent long-term outcomes are possible after heart and lung transplant. And the cost is an issue, though a lot of state governments are funding this. The government of Tamil Nadu funds by roughly around 15 lakhs for a heart and 20 lakhs for a lung transplant. So cost is taken care of. We're trying to get it included in the Ayushman Bharat scheme so that the patients do not have to spend out of their pocket. Thank you very much. I'll be happy to take questions.
Thank you, sir, for this fantastic talk. And after your talk, I think it gives a lot of confidence to all of us sitting out here that what is possible. I mean, those images of the kids having those transplants and doing so well after that, it really boosts all of us and gives us a lot of confidence referring patients for that. I'll invite the audience for any questions if they would have any. Yeah, Dr. Sonia.
Can't hear you.
What's been the 10-year survival for the lung transplant patient?
10-year survival for lung transplant is roughly around 50%. And is improving. As I said, over the last 5 years, there's been a very significant improvement in lung transplant understanding and organ preservation. And even though we started 10 years ago, our operative survival is now over 95%. So the outcomes are approaching, and in fact, identical to heart now. So I think the current generation of outcomes in transplant in this country are as good as you will get anywhere in the world.
One more thing, sir. How do you match the size of the donor with the recipient lung?
Yeah, that's important. So we take the CT calculated lung volume of the recipient and the donor. One of the few advantages of COVID is every recipient gets a CT scan. So it's possible to get very accurate lung volumes. And we accept plus or minus 20% difference in lung volume. Very often, if the donor lung is big, we might have to do a non-anatomical resection of some parts, or sometimes we remove the middle lobe. If the donor is substantially bigger, we can then do a lobar transplant of the lung.
Have you done any retransplant? Because if a child needs a lung transplant, the lifespan of that lung probably is,
We have done pediatric lung transplants, I showed you one.
the retransplant.
So the average survival of a pediatric transplant is around 10 to 15 years, but retransplant is perfectly possible.
Thank you, sir.
Sir, what is the major challenges between pediatric heart lung transplant and adult?
Is getting the organs. We don't have an organ donation in a pediatric hospital in this country. We've just signed a memorandum of understanding with the government of Tamil Nadu, and we're starting pediatric organ donation in the largest children's hospital, the Institute of Child Health. This is one of the largest children's hospitals in Asia. So eventually we need organ donations to happen in pediatric hospitals. Otherwise, we'll continue to use adult organs for children, which is not an ideal situation.
But what major challenge is if you get the pediatric
one is sizing,
yeah,
but the other thing is children actually do better. Our outcomes of pediatric transplants for heart is the 10-year survival is better than for adults. So especially in very small children, we can use ABO-incompatible transplants. Children have an immunological window which you can exploit. And infants and children up to the age of 5, you can do an ABO-incompatible heart transplant, and their long-term results are excellent, as a matter of fact. So the median survival is almost 20 years after a pediatric transplant.
Sir, myself, Dr. Haris Osaya from Ahmedabad, anesthesiologist. My question is, how do you, before getting the donors, single and double lung transplant, and keeping the patients survived?
How do you differentiate between a single lung and double lung transplant?
Yes.
Okay.
Pre-operatively, how long you can keep on surviving the patient till the donor's lung is available?
Okay, good question. When transplants first started, people were essentially doing single lung, like for a kidney. Then we found out that the functional outcomes of a double lung transplant are much better in terms of exercise. With 2 functioning lungs, you are normal. So now we reserve single lung transplant for patients over the age of 70 or 75 with other risk factors. Especially if you have 2 adults who are 75 years old and you get 1 donor, we can split 1 lung each. But the majority of patients we do a double lung transplant. Especially if patients have septic lung disease, single lung transplant is not ideal, or they have severe pulmonary hypertension.
And sir, what about the medical legal consent given by the donor?
So if a patient is being planned for a single lung, we inform them ahead of time. Occasionally, intraoperatively, we might find that one thoracic cavity is frozen, or the additions are so much, or the space is not enough, in which case we tell the patients afterwards, and we have to document that one lung is not used, and we have to have the organ distribution authority comes and inspects and makes sure that lung is not illegally given to anybody else.
And sir, little question, that is what is the name of the device? Is it ECMO or something else? You keep on patient ventilating pre-operatively.
I can't understand this question.
My question is, sir, what is the device you name or keep on patient ventilating till surgery is being done?
Sir, he's talking about ECMO. There's a bridge to
that. ECMO
is it only ECMO or something else also? Any special device?
We use ECMO, and nowadays we're using what is called ex vivo lung perfusion. So if I get a lung, say from Baroda, and the lung is borderline, and the PF ratio is 200, and the oxygenation is not perfect, we can put it through an extracorporeal perfusion of the lung, and very often it's because excess water in the lung. So over a period of 2 or 3 hours, we can make the lungs normal. In fact, there are some exciting advances. You can change the blood group of the lung. You can make the donor lung O positive so that it can be put into any recipient. And we can give high dose antibiotics to the lung because it's not going through the rest of the body so that it's cleared of any infection before you put it into a recipient.
Thank you. Thank you, sir.
Yes, Dr. Chauhan.
If suppose some heart failure patient is doing very well on HeartMate or some artificial device, and by that time they get the suitable heart donor, do you still do the heart transplant? You keep the patient on artificial lung because they are doing very well in that situation?
It depends on the patient's desire. We've had several patients who are so used to their LVAD. When a donor comes, they refuse.
You can carry on with that.
They carry on. The longest surviving in our experience is now 12 years after LVAD.
That's good.
12 years is a lifetime. And they're still going. And unlike a heart, there's no rejection. So if you look after it well, you can live for 30, 40 years with an artificial heart.
Oh, that's much better. Okay, and second thing, see, doing heart transplant everywhere is very difficult. So for all of us, what message will be there? Which are the patient in whom we should think of heart transplant, lung transplant, or heart-lung both transplant, and what are the preparations?
That's a good question. Those, clearly, you don't want to do transplants on those where it can be avoided. At the same time, you don't want to refer so late that the outcomes are compromised. So the renal function has to be intact. We can make sure, because creatinine is a risk factor. They still it will be ideal if the lung recipient is still walking. Once they are bedridden, their muscles become weak very quickly. Then the rehabilitation takes a long time. So if there are more than 3 admissions a year because of lung failure or heart failure, I would think that is the time to take an expert opinion. For lung transplant patients, I would say 6-minute walk test, which is constantly dropping despite with increasing oxygen requirements. The inability to do day-to-day activity. Then the CT scan, if it's, will tell you the progress of the disease. If there's any evidence of increasing pulmonary hypertension in the echocardiogram, all these are very strong indications that you should seek expert opinion.
So typically, who are the patient? Like patient with primary pulmonary hypertension, patient with idiopathic pulmonary fibrosis.
Are ILD, primary pulmonary hypertension, septic lung disease, very common. COPD is not as common in this country as in the Western world for some reason. The majority of our patients are actually ILD.
Thank you, sir. One last question I have, I think, yeah.
Good afternoon, sir. Sir, we had a meeting, if you remember, in Goa some 5 years back, and we had a very good debate on the heart failure patient of CRT versus heart transplant. So as an electrophysiologist, a lot of patients undergo CRT implantation. Specific focus for my is a ischemic heart disease patient. I had an ischemic heart disease with moderate to severe MR, 2 to 3 months bedridden, weighing hardly 45 kg. And already in ICD, broad QRS. Then we did a lot CRT, and now 2 months down the line, that patient has come on walking. Atrial fibrillation, huge heart. No doubt I have also advised him for the heart transplant, but economic constraints and everything. Sir, I would like to throw some lights on this subset. You had a very good discussion that how aggressively should we discuss, should we go ahead with the CRT implantation, especially in ischemic device?
It's an important question. In fact, 60% of our patients have a CRT device in place.
Correct.
Those responders who respond well.
Non-ischemic, sir, it's very good, but it's a ischemic where there is a akinetic or hypokinetic, and we know that if the septum and the lateral wall is not very, they are involved and thinned
But
out.
very often, in this country, CRT is also used for lack of alternatives. A lot of centers, CRT is not necessarily based on very precise indications. If your right ventricle is not functioning well, CRT is not going to be of great help.
Yes.
There are also patients who are on CRT device and then who deteriorate and become sicker. So our approach to patients with CRT is, if the ideal indications exist for any therapy, If the guideline indications are followed, and you follow it, you have the best long-term outcomes. But in real-world situations, ideal indications often are conflicting. Those who are ideally suited for CRT may not have the money, and vice versa. Or you might be in a situation where access to other therapies is not possible. Now there is another toy added to CRT. There is a mitra clip. So there are conflicting therapies. So it depends on who the patient lands up first.
Correct.
One word of caution with mitra clip. In my opinion, severe ventricular dysfunction with mitral regurg is not a great indication for mitra clip. And I say this not for any other reason, is you convert, very often to get that mitral valve to become competent, you require multiple clips. So you then convert a mitral regurgitation into mitral stenosis.
Yes.
So they are not candidates for a future LVAD because, in fact, one of the VVIPs in this country, a nationally well-known figure, came to us with severe biventricular heart failure after 4 mitral clips. So his gradient across the mitral valve was 15, and he was in shock. So during the LVAD, it's not easy to chop off. The clips don't come off easily.
Yes.
You end up doing a valve replacement. So with more and more devices being available, you really need better guidelines or perhaps a multidisciplinary heart team in a hospital.
I was actually going to tell you
which,
that, sir.
Which takes sensible decisions on what is the best thing to do.
We have now many hospitals with cardiologists, EPs, pulmonologists working
Sure.
together.
Thank you. Sir, one last question before we end the talk is, how difficult is organ retrieval? You're finding it. Organ retrieval, how difficult you're finding to get the organs?
Organs, actually, Gujarat is doing very well in organ donation. So you should start a transplant program
I
in
think
Baroda.
Dr. IMA team is here and Dr. Mitesh is here. I would request all of them to develop some kind of a program where we can start, Dr. Mitesh, if you can some inputs on that.
Gujarat has been doing very well this year. A lot of organs are donated. You should start a lung transplant program in this city.
Sir, Surat in Gujarat, Surat is the #1 in organ transplant because of, you heard the name of Mr. Dilip Bhai Deshmukh. He is the one of the person, he initiated the movement of organ transplant in all over the Gujarat. Now, Baroda, second or third number, we as a IMA members initiated a movement for organ donation to put up posters in a different hospital in ICU and make awareness of the people. So in next few months, we will start as this event as in a big manner.
Because even Ahmedabad is having a lot of organs these days.
Ahmedabad and Surat.
No, I know that. So as a state, you're having, that's why I told you, if you draw a line across India, north of that line, north of Gujarat, the organ donation is nothing. So a significant number of organs are still not utilized, at least for the heart and lungs. So I think with such a vibrant pulmonology and heart failure specialists, we should start seriously consider a transplant program here.
Sir, we have 114 IMA branches in Gujarat, and the state Gujarat IMA has initiated this movement. And last month we met and decide how to initiate in different city, which we are not involving till time. So I hope it will be best in the future.
Mitesh bhai, we hope that you take the lead and push through this very aggressively as you've been doing with all other things with IMA.
Definitely.
Thank you. Thank you, sir, for this scintillating talk, and I think we'll break for...
Arpan, one more question, last question. Sir, is there any minimum requirement for the hospitals to have this program? I mean, setup-wise or government legality?
Yeah, there is. Every state has requirements. The requirements are fairly standardized. You need, depending on which organ you want to transplant, the guidelines are well laid out. So I'm sure you'll have enough hospitals in this state or in this city which fulfill those requirements. That is not difficult at all.
Neeraj bhai, we need the NOTO license for organ retrieval. So most hospitals, I think, are in Baroda registered for NOTO for organ retrievals. For transplant, there are different licenses. Thank you.
So, excellent, mesmerizing talk by Professor Balakrishnan.
Just last comment. See, in Ahmedabad, they have started in SIMS hospital and other hospitals. They say they have more organs available than the recipient.
That's why
so
I said
that is the biggest problem that we are facing at the moment. Yes. So that is why we have to educate people for the indication and motivate people to get organ recipient.
I think now, if there are more questions, we can discuss with sir during the lunch time.
Thank you.
So now I welcome all the chairpersons to felicitate Professor Balakrishnan on the stage itself. I request all the audience to stand and clap loudly for this sir. Excellent, mesmerizing talk he has delivered today. I request all the chairpersons to come down the stage for their felicitation, and for which I request Dr. Dhaval Mehta, Dr. Afsana Patel and me, Dr. Bhupendra Kapadia, to felicitate the chairpersons. Now we will proceed for the lunch and we will be here sharp by 2 p.m. We will start our scientific sessions by 2 p.m.
ऑडियो इसका सेट है एचडी में ऐसे अलग कर दो ना ऑडियो सेटिंग बरोबर છે ને એચડી માં ऑडियो જતો રહેશે હવે જો આ સર આયો
इसमें कहीं